On behalf of everyone at Lupus LA, I want to welcome you and thank you for being here today. My name is Susan Bazarski. I'm the Executive Director of Lupus LA. I want to thank first Dr. Desai and her team at UCI for collaborating on this conference, and to Fate Therapeutics and GSK for sponsoring. This is our first live stream, so to everybody in the room and everybody that's streaming in, please be patient with us. We are figuring it out, so you can live stream through the link, and we're also going to post it live on Facebook. That way, nobody has an issue getting in. For those of you that are new to Lupus LA, we are so pleased to have you join us. Lupus LA serves a global patient community, and while we host a few in-person conferences each year, we offer a huge amount of content online. We do monthly Facebook Live with experts, we have virtual support groups, webinars, we have a podcast where patients tell their stories, and an emergency grant for those that qualify with some financial assistance. And we're very proud that we've nationalized that this year. It was usually, for the last 2 decades, had been for Southern California, so now we can assist patients across the country. We are truly a patient-forward organization. Our mission is to provide you with the resources and education that you need and that you deserve. We have a great program for you today with leading experts on the latest in lupus research, treatments in kidney health, and medical self-advocacy. There will be an opportunity after each speaker for you to ask questions both in the room, we'll move through, and online. You can type them in and we'll be reading them from the stream. If you don't get your question asked, if you don't get an answer, please email us at info@lupusla.org and we will forward it to the appropriate person. Before we begin, I want to ask you to take a minute to look through your folders for those of you that are in the room. Everyone streaming, we have added a link so that you can get the same content. It is the bios, the agenda, so please read through that and get to know our speakers. Our first speaker is the Interim Chair of the Department of Medicine and the Chief of the Division of Rheumatology at UCI. She is a member of the Lupus LA Medical Advisory Board. It is my pleasure to welcome Dr. Sheetal Desai. After her talk, she will also be having a panel conversation. Dr. Desai.
I think they're trying to see if we can get a mic so I can walk around. If not, until then, I'll just kind of stay right here. So thank you all for coming. My name is Sheetal Desai. I'm one of the rheumatologists here at UC Irvine. Our medical center is right behind us, so that's why we purposely chose this location. We've been actually doing these Lupus LA events here in Irvine since 2014. So we did them annually up until the pandemic. During 2020, I had done it virtually, and then it kind of fell off, and this is the first year we're bringing it back. So we're really excited. Thank you all for coming. I will be focusing on lupus nephritis. Our clinic here at UCI is the only clinic on the West Coast where you have a rheumatologist with a kidney specialist side by side. So as we see our patients with lupus kidney involvement, they see me, they see the nephrologist, they'll see our nurse, and they get really nice comprehensive care. So we've been doing that now since 2012, and I've learned a lot by working side by side with our nephrologists. So the title of my talk today is actually, I'm gonna see, let me go through this, let's see. Do I go through this? Okay, perfect. Title of my talk today is Lupus in the Kidneys. I will go through it. It's about 40 slides, and my hope is by the end we'll have a little bit of time for questions that you all may have. So why are we talking about the kidneys? Who cares about the kidneys when it comes to lupus, right? So it's a big thing in the lupus world, and the reason it is because 1 out of every 2 patients with lupus actually get kidney involvement. And I want to say that again, it's 1 out of every 2. So 50% of lupus patients. And it tends to be more common and more aggressive in all of our minority patients. So our white patients get lupus in the kidneys, but my black patients, my Latina patients, my Asian patients, they get kidney involvement and it can tend to be more aggressive. So I want everyone to be aware that kidney involvement happens in about 50% of lupus patients, and you may not know at all. It is silent. No one comes and tells me, hey, I'm worried my kidneys are involved, because the early stages, they have no idea. How do we know? Is we pick it up on their urine and their blood work. So that's why we try to really socialize the importance of lupus patients coming and seeing us in clinic at least quarterly. Because I'll tell you what happens sometimes is they feel fine, they're doing good, or it was COVID and they didn't want to come in, and then fast forward a year or two later, I actually meet them in the emergency room or in the hospital, because then they had silent kidney involvement that actually got worse and resulted in them going into the emergency room. So know that the involvement is silent. It's something we screen for every time a patient comes to clinic, and that's why you got to do the urine sample. And look, no one really gets excited about going and peeing in a cup, but it's peeing in a cup. That's all it is. It's not invasive, but it's the easiest way to screen if you have any findings that would suggest that we need to screen you further. Okay, 1/3 of our patients with lupus actually develop kidney involvement in the first year, and most people that get kidney involvement get it within 5 years. So if you have lupus and you've had it for over 5 years, this is not something you have to stress about too much. It can happen, but it's really unlikely to happen after 5 years, right? So I just want to let you all know, it tends to happen early in the course of the condition, when the condition is really active, really aggressive, and that's when people tend to get kidney involvement, right? But we still screen for it. Even if you're a patient of mine that's had lupus for 10 years, 15 years, it's such a simple thing to screen for during a urinalysis. So I do it at every visit regardless. And it's interesting, some patients with lupus don't even know they have lupus. They actually have some findings on a urine, their primary care doctor sees that, sends them to a nephrologist, then the nephrologist does a biopsy and says, oh, you have lupus, and they send them to me. So 1/3 of all of our patients actually with lupus present to a kidney specialist and then are rerouted to me. So I just want to give you an idea of sometimes how this is actually diagnosed. So again, how do we screen for kidney involvement? It's not going to be you telling me something. It's not going to be you saying, oh, my back hurts. That's kind of where the kidneys sit. That's usually not signs of kidney involvement. It will be findings that I see on blood work and on the urine. And I'm going to walk you through what we actually look for. So when you do a urinalysis, that's when you give a sample. I just had to do one last week, so we as physicians do them as well. You got to really wash your hands. You kind of miss the cups sometimes. It's for the women. The men, it's a lot more simple, but for the women, it can get really annoying, right? So what we look for is we look for protein. We all sometimes spill a little bit of protein. I'm not stressing about a little bit of protein. So if you ever get your labs from Quest or LabCorp and you can see it and it says trace or it says 1+, I wouldn't stress out too much about it. We're looking for a lot of protein. Then we ask the lab to go ahead and quantify it. And we want to see if there's signs of inflammation. So not just protein, but white blood cells, red blood cells, okay? So protein, we all eat things every day, and then our body breaks it down into the building blocks that we need, one of which is protein. The job of the kidneys is to filter all the protein back into the blood. So the kidneys should not be spilling protein into the urine because your body wants to hold on to protein to use it for building blocks, right, for your daily use. So what happens if your kidneys are inflamed, they're not working normally, they will spill extra protein into the urine. And so when we see too much protein in the urine, we're already thinking, shoot, something might be happening in the kidneys, and then we go ahead and get further tests, just to give you an idea of why we look for protein. White blood cells are a sign of infection and inflammation. So sometimes there are white blood cells, but the patients might say, I have burning when I urinate. There's an odor to my urine. That might be something completely different like infection, and that may not be a sign of your lupus being active, but then we can do additional tests. And the last thing I look for is red blood cells. That's also a sign of inflammation. But what do you think happens with women between the ages of like 12 and 50? That causes red blood cells in the urine that has nothing to do with lupus, right? It's our periods, right? So when women have a menstrual period, I used to tell women, come in and get your blood work. The menstrual period is not going to throw that off. And then come back and get the urine later. That's what I used to tell all my lupus patients. Well, what do you think happened? People wouldn't come back to get their urine, right? It's already hard enough to get your blood work, your urine, and then see your doctor. And then everyone has a life. They have a lot of things going on. They forget to come back and get their urine. So I've stopped saying that. I used to tell people, skip the urine when you're on your period, come back and redo it. But then I found people just don't have the time. They don't have the time to come back and redo it. And you fast forward and it's 4 to 6 months later, I'm seeing them again, and then they're doing your urine. So what I tell people is I don't care if you're on your period, do the urine. All the period will do is just kind of mess up the red blood cells, but the rest of the things, the lab is pretty darn good at actually evaluating the protein, and if I ever see something off, we'll repeat it again. Okay, so you can do blood work and urine despite being on your menstrual period. It is A-okay. All you do is tell us when you come to clinic. So when I see a lot of red blood cells in the urine, my first question is, dear, were you on your period a week ago or 2 weeks ago or 3 days ago? And they'll say yes, and then I don't stress out too much about the red blood cells. Creatinine. How many of you have seen this on blood work? Right? It's a blood test. It'll say creatinine. Just to explain what it is. So creatinine is a measure of muscle breakdown. We usually go through that on a daily basis at some level where we're constantly breaking down some parts of our muscle, and then that releases creatinine. The kidneys normally filter all the creatinine, or the majority of it, and secrete it into the urine. So you want to think of protein and creatinine as opposite. The kidneys will filter protein and keep it in the body, but they will filter out creatinine. So when we look at the serum or the blood level of creatinine, it should be low. But if the kidneys are inflamed and not working well, they're going to spill all the protein and they're not going to filter the creatinine. So your blood levels of creatinine go up. And that's why we look at both creatinine and a urine protein to give us an idea of how the kidneys are doing, right? Kidney involvement, like I said, is usually silent, but when will a patient notice it? If the kidney involvement has become very active and it's been going on for a bit of time, and now they're spilling so much protein that they don't have enough protein in their blood, which actually keeps the fluid in the blood vessels. And if you don't have enough protein in your blood because you're peeing it out from your kidneys, you will actually get swelling happen in your body. So sometimes what happens is patients will come in or go to the emergency room urgently and their feet are swollen. Their whole body is swollen. They'll tell me that their urine is very foamy. If you've ever seen bubbles, a lot of bubbles in the urine, and it's really foamy, like it looks like you've mixed it with soap, that's a sign of a lot of protein in the urine, right? So I don't often get this in early stages, and that's why I try to tell people to get their urine done so we can pick it up early on. But when there's a lot of protein, we'll go ahead and patients will actually tell us it's really foamy. So when do you need a kidney biopsy? And we'll have a panel up here where I'll have a couple of patients who have had kidney biopsies, so that way you all feel comfortable about it, because it can scare anybody. People hear the word biopsy and they know it's an internal organ, and listen, I hear you, that it sounds absolutely terrifying. But it's not, and it's a very common outpatient procedure. So when do I recommend patients for a kidney biopsy? It's not when they have a tiny amount of urine. It's when it's a tiny amount of protein in their urine. It's when they have 500 milligrams or more. And a normal individual who doesn't have diabetes, because diabetes will also cause protein in the urine, but a normal individual should be spilling like 50 milligrams, maybe 100 milligrams of protein, but once you're spilling 500 milligrams or more, then we try to get a kidney biopsy. And in the past, they used to say 1,000 milligrams or more, but all the newer updated guidelines are saying, why are you waiting for 1,000? Even at 500, you know something is going on. You'd rather pick it up early than wait until it gets more active. So we do a kidney biopsy when people's urinalysis shows me they're spilling 500 milligrams or more, or their blood levels of that creatinine are higher than I would like, and I'm trying to figure out what's going on. So a kidney biopsy, most people are not admitted for the kidney biopsy. Now, if they're in the hospital, they're diagnosed with lupus in the hospital, sometimes we'll tag on a kidney biopsy at the same time. But if you are not admitted just to get the kidney biopsy done, it's an outpatient procedure. You'll go in, they'll do the biopsy, they'll watch you for maybe an hour, a couple of hours, and then they'll send you right home. So you will be able to likely sleep in your bed that night and the night before. So I just want to give you an idea. It's usually very safe. Most of our patients have actually had not just one kidney biopsy, but 2 or 3. Because the only way I know what's going on in the kidneys is getting a biopsy. So sometimes I'll get a biopsy in the beginning, and then we treat the patients. And then something just doesn't make sense. Their protein goes up, their kidney function doesn't look good, or they're not responding to the therapy, and then I have to get another biopsy. So most of our patients don't just get one biopsy, they get a couple, and it really helps us understand what is going on in the kidneys, because you definitely don't want to get treated for something you don't need treatment for. And so I'm going to give you some examples over the years. I've had a lupus patient who actually had lupus since she was 4 or 5. She had lupus in the kidneys from a very young age. Fast forward, I'm now taking care of her through her pregnancy. She's in her late 20s, early 30s, she's pregnant. All of a sudden, she had a ton of protein in her urine. We didn't know what was going on. She was 20 weeks pregnant. We assumed it was her lupus because she had lupus in the kidneys a decade ago. So I started treating her with prednisone and medications that were safe in lupus. And then after she delivered, because we don't do biopsies if we don't have to in pregnancy, we try to avoid it. After she delivered, the protein didn't go away. So we biopsied her, and it wasn't lupus. It was diabetes. So I just want to give you an example that sometimes you need a kidney biopsy to show you what's going on, because that completely changes everything. I dropped her prednisone, we stopped it, we decreased her meds. She had long-standing diabetes as well, and that's what was causing the protein in her urine. I had another patient who has lupus and this blood clotting condition that about 1/3 of our patients with lupus have, called antiphospholipid. When she got the biopsy, it showed not just lupus, but antiphospholipid clotting changes, and that allowed me to add additional medicines to calm her lupus down. I've had multiple patients in the last couple of years that I get a kidney biopsy on, and it doesn't show their lupus is active. Well, then why am I giving them all of these medicines? That helps me start titrating down some of the medicines we use for lupus kidney involvement. So just giving an example of how a kidney biopsy is super important to me. And our bodies aren't the same every day. So you can get a biopsy a year ago, and you can get it this year, and you might find something different, because our bodies adapt and change. So it's not like what you see in the past may hold true today. When we get a kidney biopsy, there are 6 stages that are read out. Actually, let me clarify, 6 classes. Don't think you're going to go from 1 through 6. That's not how it works. They're just different classes of lupus nephritis. I don't have class 6 up here because class 6 just means it's completely scarred, burnt out lupus, and we don't usually treat it. Class 1 and 2 are early classes of kidney involvement that don't even require a lot of therapy at all. It just helps me know that, look, there's something brewing there, but there isn't enough that I need to actually give patients medications. Classes 3, 4, and 5 are the most common, and at the bottom, you might be able to see I have the percentages. Class 4 is the most common. If I had to guess, I'm gonna guess most of my patients have class 4, over 50% of them. Then class 3, about a quarter of our patients will have them. Some patients will have more than one class. They'll have 3 and 4, they'll have 4 and 5, 3 and 5, and then we have about 10% who just have class 5. The classes help us gauge how active it is, how aggressive we need to be with our treatment, just to give you an idea. But people don't progress from 1 to 2 to 3 to 4 to 5 to 6. So that's not how I want you to think about it. So when people come in and they go, oh my God, I'm class 4, they feel like they've progressed all the way through, and I go, no, that's just the most common class of lupus nephritis that we see. Bless you. So treatment of lupus nephritis, I want to break it up. It's induction therapy, where we kind of give a little bit more stronger medicines to calm the inflammation down. And then it's maintenance therapy. And I'm just watching the time. We're doing great on time, right? Yeah. Okay, good. So induction therapy, it's super important to calm the kidneys down. I have this picture in my clinic, and I show it to patients just so they really understand. This is a clinical trial where they were actually showing what happens to patients with lupus. So let's take someone without lupus, okay? If someone doesn't have lupus, naturally over their lifetime as we age, our kidney cells don't work as well. And as we age, the function of our kidneys slowly decline. These are for people that have no lupus, no diabetes, nothing else. So this is the blue graph right here. So you could see in your 20s, your kidney function is normal. As you age, it declines. Let's say you live until you're 100 years old. You're going to be approaching dialysis, just to give you an idea. Okay? So that's what happens with normal individuals who have nothing, no medical problems that affect the kidneys. What happens with any of my patients with lupus nephritis? As soon as they're diagnosed with lupus nephritis, their kidney takes a hit, and their entire graph is shifted down. Okay, so there's some changes that no matter what I do with therapy, I can't fully pull back. Now that patient is on a totally different curve, and if I don't treat them well, they will continue to go down, and they will actually approach dialysis at a younger age. And if we do nothing, they will approach dialysis within a couple of years. So why do we treat patients with lupus nephritis? Because if we don't, they will actually go on to dialysis, and their kidneys will fail. But with treatment, my goal is you don't need dialysis until you get to numbers down here. So my goal is, even though your kidneys have taken a hit, I want to keep you stable, and I want the curve to kind of go like this. Does that make sense? So I want to keep you as far away from dialysis if I can, and that's why we monitor the meds, we monitor the urine, and if things aren't going well, then we go ahead and repeat a biopsy to understand what's going on. So I share this just because it's so important to understand the big picture, because it's hard. It's hard when patients are 16, when they're 18, when they're in their 20s, when they're in their early 30s, and they're getting diagnosed with lupus kidney involvement. They're going to school, they might be in college, they might be in a relationship, they're starting a family. No one has time for this, and I don't blame them. Seems like a pain when you're having to come in and see a physician, when you have to go to the lab every quarter, but that's why here at UCI we try to combine our care. We try to do it with the kidney specialists. They spend a whole morning with us, but at least they're spending one whole morning seeing both me and the kidney doctors, and it's happening quarterly, as opposed to them seeing multiple doctors all the time. But it's so important, because what happens is sometimes I'll get patients when they're young, don't recognize the importance of it, don't recognize what could happen, skip out on appointments, and then they end up going into end-stage kidney disease and dialysis, and then they totally get it. And they're a lot better with their medicines, they're a lot better with follow-up, but then I can't do a lot. Does that make sense? So I don't show this to scare patients, but I show it so patients understand what I see on my side and what I'm trying to prevent as much as possible for any of my patients. Right, so initial therapy or induction therapy, it's usually for the first 6 to 12 months. My goal is to get the kidney inflammation under control super fast as I'm able to. I use prednisone at moderate to high doses, and we'll go over that in a second, to calm the inflammation down. Prednisone is still the fastest acting drug we have for inflammation. I don't know if you all know, but it was a rheumatologist that actually discovered prednisone in the late 1940s at Mayo Clinic, and Philip Hench, and he actually got a Nobel Prize. And I tell my fellows every year, if you can just find a new form of prednisone that doesn't have a ton of side effects, you will be the next rheumatologist to get a Nobel Prize. Because if it didn't have side effects, that's all we would use. Because it works amazing. It calms the inflammation down right away, but there are a lot of side effects. And that's why what we do is we start with prednisone, we start other medicines, and then we try to taper the prednisone down. And there are two major medications we use to calm patients' lupus down. One is Selcept, and one is Cytoxan, and we'll go over each of them a little bit more, but those are the two initial medicines, one of them that we like using to calm the lupus down. So just a quick overview before I go into the medicines a little bit more. We screen the urine every time you come in. If I see protein about 500 milligrams or more, I'll check it one more time. I won't send you to a kidney biopsy with just one value. I will confirm it to make sure it's accurate. If you're spilling more than 500 milligrams of protein, we'll go ahead, or your blood levels of creatinine are abnormal, we'll go ahead and get a kidney biopsy. I'll confirm that it's actually lupus. Not that it's diabetes, not that it's something else, but if it's actually lupus, then we'll go ahead and begin treatment. We'll give prednisone at higher doses. We'll choose based on your case what medicines we think might work well with you and what medicine you're comfortable with. We'll choose either Selcept or Cytoxan, and then I try to taper the prednisone. And then if things aren't going the right way, I'll actually add other medicines, which we'll talk about. So our goal in lupus nephritis is you gotta get the protein down. I've had people with 1,000 milligrams of protein in their urine. I've had people with 3,000. I've had people with 12,000 milligrams of protein in their urine. So some people can spill a ton of protein. My goal is to get the protein in the urine that is spilling down to 500 to 700 milligrams. My goal is to do it at 1 year. Sometimes it doesn't always happen at a year, and it might take a couple of years, but that's my goal, to get people there, and I will keep trying different things until we can actually get patients to that goal. So this is how we feel about prednisone. This is probably how you feel about prednisone. It really is a love-hate relationship. We love it because it works fast, calms things down right away. If someone has a lupus flare, we give you prednisone because you're going to feel better within 24 to 48 hours. But it's all the side effects of prednisone that we worry about. So no, we can give you prednisone orally in tablet form. We can give it to you IV in the hospital. We can actually give it to you as an injection in clinic as well. So I have some patients who go, don't increase my dose. I'll take a shot in clinic, a shot of 40, 60, 80 milligrams. It'll actually work for about a week or two, and sometimes they prefer that as well. It's a fasting drug we have. But look at the side effects. When people are on prednisone long term, they can have elevated blood sugars, they can get diabetes, they can get high blood pressure, they can get elevation in their cholesterol level. It causes osteoporosis. So all of our young patients who are started on prednisone, we're now getting a bone density scan after they've been on it for a certain amount of time. It definitely causes acid reflux, it can cause stomach ulcers, they get a lot of bruising. It can actually play with your mood, and it can make some people really anxious. It can make some people really depressed. So sometimes we have to actually play around with the dose to find a dose that can actually calm their lupus down, but not cause a lot of changes in their mood as well. It can cause swelling. I mean, the list goes on and on. It can cause swelling in the body. It can cause swelling in the eyes. So sometimes I get people who are started on prednisone and Plaquenil, and then they tell me they want to stop the Plaquenil because they think it's affecting their vision. But it's actually the prednisone causing swelling in their eyes, causing blurry vision, and often not the Plaquenil. So just to give you an idea, if you ever get side effects from meds, I always think of prednisone before I think of other medicines because it just has the potential to cause a lot of side effects. And it doesn't mean you're going to get everything, but you just got to be aware why. We try to use it when we have to, minimize its use, and try other medications. Mycophenolate mofetil, this is Cellcept, depending on what name is actually on your medication bottle. It's been shown for lupus nephritis to be just as good as cyclophosphamide, or the other word is Cytoxan. Cytoxan is IV. The beauty of this medicine is it's a pill. And so I tell you across the country, even though I said we have 2 different medicines we can use to treat lupus nephritis, 75% of the time we use Cellcept. Because it's oral, it's easier for people to take. About a quarter of the time I'm using cyclophosphamide. It needs to be taken twice a day because of how your body absorbs it. So it's usually 2 to 3 tablets twice a day. Sometimes patients will say, can I take all 6 altogether? You can, but if you do, you're gonna actually excrete or get rid of half of the drug. So that's why we tell people you take half in the morning, half in the evening to ensure that you can absorb the drug fully. It can bother the stomach. If it does bother the stomach, there's an enteric-coated form called Myfortic that we can switch it to. Usually if I start with Myfortic, the insurances don't cover it. So I have to first start with Cellcept. You gotta tell me, and we'll ask you if it bothers your stomach, and if it does, we swap it to the enteric-coated version. And the daily dose really depends sometimes on your race and ethnicity, because we've had a lot of studies out of China showing in our Chinese patient population, maybe a lower dose works just as good as a higher dose that we use in all of our other minority patient populations. So sometimes we'll actually play around with the dose that way. Mycophenolate mofetil or Cellcept needs monitoring. So just like you get labs done for lupus, it is honestly the same labs you're going to do for monitoring of Cellcept. So it's not extra labs, but we need to make sure your blood is okay with it, your bone marrow is okay with it, your liver is okay with it, your kidneys are okay with it. But the beauty is the same blood work you already do to monitor your lupus actually works to monitor the medications as well. And something that we really highlight in our clinics is you gotta be aware that this medicine is teratogenic, which means it definitely causes birth defects. So you cannot be on this medicine if you're trying to get pregnant. And I highly tell our patients you should be on birth control, because we all know that no birth control is not a good thing, and even using barrier protection methods like condoms, it has a rate of like 80% success rate, so 20% of the time, people could actually get pregnant. And the last thing we want is someone to get pregnant on a teratogenic medication. So in the last, 18, 19 years I've been here at UCI, I've had 2 women have oops pregnancies on Myfortic. And I share this experience with my patients so they get it. The first one, I basically, as soon as that happens, I have to refer them to OBGYN because I can't actually counsel them on the birth defects. Our OBGYN physicians do, and then they weigh the risk and benefit and decide if they want to keep the baby. My first one, religiously, she did not want to do an abortion. She held on to the baby. She delivered the baby. Her daughter, now beautiful, is doing great. But when she delivered her baby actually had spinal cord defects where the back was completely open and needed 3 surgeries in the baby's first year of life at UCLA to close the back and the spinal cord. So I just want to give you an idea. Her daughter now is over 10 years old, doing fabulous. But this is why, when I saw that, this is why I really want to avoid it as much as possible. And then my other patient opted for actually doing an abortion, right? But I don't want any of our women to be to kind of have to cross that bridge where they have to evaluate whether they want to keep the baby or whether they want to go through with an abortion. So it's so important, if you're on CellSept and if you're sexually active, to ensure that you have birth control. And the one that we recommend the most is an IUD, because all of you are taking medicines already. I don't know if I want you to take another pill when you're already taking a bunch of other medications. Sometimes getting an IUD placed, it's absolutely safe with lupus, whether it's a hormonal or a metal type IUD, a copper IUD. It doesn't actually interfere with lupus, and it's something you don't have to think about until you want to actually get pregnant in the future. So I just wanted to spend a lot of time on the fact that it is not safe in pregnancy. And so we really want you to be on contraception. In the past, I would talk to my women about it, and they would say, well, let me think about it. And that's when the oops kind of things happen. Now I'm a lot stricter, and if you see other private doctors, they may not even prescribe CellSept unless they know that you're on some contraception, because they don't want to take the medical legal risk on them or on you, right? So I just want to give you an idea why we really push that quite a bit. Cyclophosphamides. Remember I tell you there's two medicines for treating lupus nephritis, CellSept and Cytoxan. CellSept is what we use probably across the country in over 75% of patients because it's oral. Cyclophosphamide is the true grandfather of all lupus drugs. If nothing else works, this drug works. This drug has been on the market for 40, 50, 60 years. It's been used in lupus and lupus nephritis since the 60s, 70s, and 80s. And this really is an amazing medicine. It is given IV. It's given over 6 doses. Depending on the dose, you can get it monthly for 6 months. Or if the dose is a little lower, you can get it every 2 weeks for 6 doses. It does work really well. It's also teratogenic, so we avoid it in patients who are currently pregnant, and it can affect the ovaries. So if any of you are my patients listening or here in the room, if you were a certain age, I wouldn't have given you this option, because cyclophosphamide is a chemotherapeutic drug that can affect the ovarian production, and if it's given to our women 30 and above, it can actually cause premature ovarian failure, which if they've already had kids and they don't mind, that might be something we'll talk about. But if they haven't had kids, they haven't done family planning, I don't want to go ahead and shoot down their ovaries and stop that potential in the future. When women are younger, when they're in their 20s, when they're in their teens, it's not a problem. There is enough years and enough cells that they actually do okay. When I have women who are between the ages of 25 and 30, and it is an option that we want to give patients, I will give them another medication called Lupron to go ahead and protect their ovaries while they actually get this medication. So I just want to let you know, most of my women patients above the age of 30 and above, I try to avoid it unless we have no other option. And if they're between 25 and 30, I have medicines to actually protect the ovaries, which minimizes the toxicity of cyclophosphamide. And if they're in their teens or 20s, early 20s, it's not a problem. They actually do quite well with this medication. So I use it, but like I said, I use it in about 1 out of every 4 or 5 of my lupus patients. And the one thing is, bless you, the one good thing about this is it's IV. So when I get patients who it's really hard to take the pills, they can't remember to take the pills, their kidney inflammation is still at a high level, and because they're not able to be compliant with taking their pills, we really need to treat their kidneys fast and calm things down, then we'll actually talk about cyclophosphamide. Or if they've tried the CellSept and it's not enough, we'll go straight to cyclophosphamide as well. So just want to give you an idea. 2 different medicines for lupus nephritis, one that's IV, one that's oral. We tend to use CellSept still the most, but I still use this medication in a percentage of my patients. So I want to show you from the 15 to 18 years of me treating lupus nephritis, I thought we were doing really good across the country and across the world. And despite us, and this shows you that most people with lupus nephritis actually develop it within the first 5 years of diagnosing with lupus, but still, no matter what we did, we still had about 20% of our patients go onto dialysis, and still their kidneys don't respond well enough, and they still fail therapy with either Cytoxan or Cellcept. And I couldn't figure out why, despite us being a lot more aggressive at treating our patients, they still fail. And that's why we need about 1 in 5. And in this era now, we have additional medicines that are FDA approved for lupus nephritis. And so in this era, what we're trying to do, and that's where it's the latest on lupus, when I gave this talk about a decade ago, we just had Cellcept or Cytoxan, and I would just tell people, we really try these things, we keep trying them, and we try to get people's protein levels in their urine down. Well, there are people that sometimes, despite either of them, it was not enough. But we didn't have other FDA-approved medications to help us, but now we do. We have Benlysta that was FDA-approved first in 2011 for lupus, but it was FDA-approved in 2020 for lupus nephritis. We have voclosporin and tacrolimus, a family of medications that have been FDA approved for lupus nephritis. And if either of those two FDA approved medicines don't work, then we do clinical trials at UCI and have other medicines like rituximab, which I'll briefly talk about. So Benlysta, this medicine was first FDA approved in 2011. Fast forward now, almost 15 years later, it is FDA approved in adults. It's FDA approved for lupus in kids 5 and above. It's available IV, it's available as an injection, and it's FDA approved for lupus nephritis. This is a medicine that's been on the market for over a decade, that every couple of years has just gotten more indications, is very well tolerated. Like I said, it can be given IV once a month. It can be given as a self-injectable that you would do at home once a week, so if you don't want to come in. And it has been shown to not just help lupus, but when added to either Cellcept or cyclophosphamide, it can actually help improve the treatment of lupus nephritis. So when Cellcept or Cytoxan are not enough, we have this medicine we can actually add to it. It's pretty well tolerated. The side effect profile is minimal, and I would say, God, over 90% of my patients I've started on it have actually been able to maintain and stay on the drug. So really a well-tolerated medication. We then have to see if it actually is efficacious for them or not. And I'm not a fan of giving people medicines that don't work for them. So if they try it for 6 months or so and it doesn't help them, we'll stop it and we'll try a different medication. Loop kinase, you might have heard of this medication, or voclosporin. It was FDA approved as add-on therapy. So these new medicines are add-on therapy. They don't replace the Cellcept or Cytoxan. They can be added to them if the Cellcept or Cytoxan are not sufficient. And so voclosporin, which is loop kinase, is actually a medicine that is an updated version of an older medicine that's been on the market called cyclosporin. And that medicine has been on the market for decades. And so it's actually the way they updated an older medicine, it decreases the adverse effects. It's so much better tolerated. It's given as, it's pill form, so it's not IV. It's given as 3 pills twice a day. And I thought that was a lot of pills, but I've seen the pills, they're really tiny. And my patients who have been on this medicine say that it's really not that hard of a pill to take. Then the question is can they tolerate it? So I have to make sure that they don't get high blood pressure from it. I've got to make sure their kidneys tolerate it pretty well, and they don't get other side effects. And if they do, this drug can be really wonderful at treating lupus nephritis. Tacrolimus is a sister of that drug, very similar. The difference between these two drugs is this one is safe in pregnancy, this one is not. When they developed this drug, they actually had a tiny amount of alcohol they added to the formulation. So tiny, it's like 1/8 of a tablespoon twice a day. Right? It's really tiny, but because there's any alcohol in the formulation, it can't be given when our patients are pregnant, and we just switch them to their sister drug, tacrolimus. which has been on the market now for over a decade and very similar to the last medication. Rituxan is another medicine we've borrowed from the cancer world. It's a medication that's been around since 1997 to treat lymphoma. We borrow it to treat lupus. It was in clinical trials for lupus kidney involvement, and it just didn't make the cut. So just know it's not FDA approved, but in some people, when I add it to their other therapies, it can actually help them. Maintenance treatment. So let's say I give people Self-Advocacy, I give them Cytoxan, one of the two. I get them under the control, or I have to add Benlysta or voclosporin, and we get them under control. Once they're under control, then we got to give them maintenance therapy. So the inflammation's here, we bring it down to here, and then we need to give you something to maintain it. Selcept is the gold standard for maintenance therapy. So if you get Cytoxan IV, you'll switch over to Selcept. If I started with Selcept, you're just going to stay on Selcept. And the goal is to stay on this medication once we control the inflammation for 3 to 5 years. Because we know lupus nephritis is really finicky, and if you just start decreasing the medicine too early, it can act back up again. So the average is about 3 to 5 years. Do you know what's the only medicine that we have of all the medicines on the market for lupus that actually prevents kidney inflammation? It's a medicine I haven't talked about.
Plaquenil.
Good. So it's Plaquenil. It's my favorite medicine, but it's the mildest medicine out there. So if you have active lupus, you're not going to feel like Plaquenil did a lot for you maybe, but it's a great medicine that when given over time reduces the intensity of lupus flares, increases the time between lupus flares, treats skin rashes and joint pain. If it's efficacious enough, it improves longevity in all of our lupus patients. It helps prevent kidney inflammation and helps prevent blood clots. So I just want to let you know we give Plaquenil to everybody. It's super important to me. It's been FDA approved since 1955. It's the mildest medicine. But once we get your kidney inflammation down with the prednisone and Selcept and Cytoxan and whatever we use, it does a great job of keeping people there. Where I've had patients 5, 7 years out, they were just on Plaquenil. They stopped taking it, and then their kidney inflammation came back. So I just want to give you an idea. Plaquenil is a great medicine. The risk of eye involvement is really, really low. As long as you follow up with an eye doctor once a year and get an eye exam, we can pick it up. So overview of lupus nephritis. If you got to get a urine, I'm not going to know if you have kidney involvement until you get a urine. If there's more than 500 milligrams of protein consistently over multiple times, we get a kidney biopsy. We make sure it's actually lupus and it's active. We give prednisone to immediately calm it down. We choose between Selcept or cyclophosphamide, only 2 drugs we choose from. We try to taper the prednisone, but if it's not enough, I quickly, by the 3 to 6 month mark, if you're not getting enough improvement, I will go ahead and add on other medicines, either Benlysta or voclosporin, to prevent you from going down to dialysis or needing a kidney transplant. And so our American College of Rheumatology came up with updated guidelines that they just published. They just actually put out, it's on the internet, in October, November of 2024. And they're actually saying, don't just start with Selcept or Cytoxan. Start with combo therapy. Combo therapy is better than starting with one drug. So they're actually recommending start with Selcept and Benlysta. Start with Selcept and voclosporin. Start with cyclophosphamide and voclosporin. They're recommending do combo therapy from the get-go. So I'm just letting you know that the tide of treatment of lupus nephritis might be treat it really hard early on, calm it down fast, so people do really good. We want to prevent our patients from going onto dialysis or kidney transplant. It still does happen. We have our kidney transplant specialist here at UCI, Dr. Reddy, coming and speaking on kidney transplant, just so you're aware. We have a kidney transplant center, and our patients actually do really good. And once they get a kidney transplant, do you know the only medicine we have that prevents the lupus from coming back in the transplanted kidney? Any idea which that one is? It's Plaquenil. So I just want to give you an idea. Plaquenil has a lot of benefits despite how mild it is. So just questions and we're done. How common is kidney involvement in lupus? 1 out of every how many people will get kidney involvement if you have lupus? 1 out of 2. And I want everyone to know that, and I want our lupus patients to know that, so they know why it's important to come and follow up and not kind of get lost to follow up, and then I kind of meet you several years later, unfortunately, if you get kidney involvement in the hospital. True or false, can you feel lupus inflammation in your kidneys? Right? Usually you don't. You might feel a lot of other things, but you're not going to feel lupus inflammation. So that's why I need you to come to clinic. What is the best medicine to prevent lupus kidney involvement? It's Plaquenil. So when I get my lupus patients, they may not have kidney involvement, but I start them on Plaquenil right away. And if they're really good about taking it, maybe it can prevent it, or it can actually drop down the level of inflammation. Is a kidney biopsy safe? It absolutely is. It doesn't mean rare things can't happen, but we will evaluate if you're a high-risk patient, and we will strongly encourage you to get it done if we feel like the benefits outweigh the risk. And the best initial therapy for lupus kidney involvement, there are 2. It's cyclophosphamide or Celcept. We're using a lot more Celcept, but now we're going to maybe do combination therapy with either of those agents plus Benlysta or voclosporin as early as possible, because our goal is to prevent dialysis and to prevent you from actually going, to transplant. So is combination therapy for lupus nephritis, does it have better results than using one drug? Absolutely, and that's the change we're going through right now, is recognizing we got to be more aggressive. From a patient perspective, I never start 5 drugs at the same time. I still take several months to start the prednisone, the Plaquenil, get you accustomed to Celcept, make sure you know what medicine is causing what side effect. So I will never start 5 meds at the same time. I will start them and kind of ramp them up over a period of several months. So then you feel comfortable, you know what you could tolerate, and then we get you to combination therapy by about the 3-month or 4-month mark. And I will go ahead and end here. Thank you all.
Thank you so much, Dr. Desai.
And you know what we might do is we might go straight into the panel.
Yeah,
and then
but
maybe we'll take questions then.
You
What do
want to take
think?
questions at the end, because you have questions both on streaming and I'm sure in the room, but it just all sort of wraps up at 11:30, so it's however you would like to use your time.
If we have about 5 minutes, we could take some questions
Great.
now.
So I'm going to start with one online, and then we'll grab one in the room.
Okay.
So somebody streaming asked, how long can you be on prednisone in a bad flare before you develop prediabetes or diabetes?
That's a great question. So how long can you be on prednisone before you develop prediabetes? It's really hard to say. Everyone's different. It depends on your genetic risk, your predisposition to diabetes. I'll tell you that taking a 1-week Medrol pack, a 2-week Medrol pack, couple of these short courses of prednisone will unlikely tip you over to diabetes. It's more if you're on prednisone chronically, daily, for a period of time. And some people, it can be just a couple of months that tips them over. I have a patient of mine who's been on ridiculously high doses of 40 milligrams of prednisone for years. She has no weight gain, no diabetes. I mean, I just keep looking at her wondering, I don't know how your body metabolizes this, but it blows my mind. So it depends on patient to patient. That patient is an outlier. But if you're just getting it for a week or 2 weeks here and there, that shouldn't tip you over. But if you're on it chronically, it'll depend on your predisposition how quickly it'll tip you over. Yeah? And then I think I had a question up here first, and then we'll get to you as well. Yes? And I'll repeat it. Oh, perfect.
Okay, you're talking about lupus nephritis. Now, I have discoid lupus, which is a different rare one, and I've been on Plaquenil for over 32 years now. And so would I be seeing you? Because I haven't been able to see a rheumatologist at all.
Yeah, so discoid lupus has a lower rate of progressing to systemic lupus and lupus nephritis, so that's great. Doesn't mean it can't happen, but if you're 30 years out and you've been on Plaquenil, which has been very protective, maybe that's why you haven't developed more of a systemic form, and it's unlikely to develop kidney involvement this many years out. So hopefully we'll be very good.
So I
Right.
would need to see like a different room, because I've been trying
No,
to find a
dermatologists treat discoid lupus. So sometimes what happens is if it's really just skin and they don't get systemic involvement, they may not send them to us. They might be able to go ahead and take care of them. It's when they get more systemic that they actually send them to us in rheumatology.
Yeah, so I would see you, or would I see the next panelist person coming up, the other rheumatologist?
You could see any rheumatologist. All rheumatologists treat lupus.
Because I live in Redlands, and everybody who I've been trying to contact,
Yeah.
they said, oh, we're not taking any patients.
Well, we could talk more probably at the end about that. So I'm just gonna highlight people maybe going over specific personal things might be a little difficult. We'll kind of go over in this setting, but happy to talk to you kind of at the end a little bit. Yeah, absolutely.
Thank you so much, Dr.
Yeah.
Desai. The next question online.
Okay.
Is a low-protein diet better for kidneys to avoid nephritis, or in lupus, does it not make a difference?
It's a great question. A low protein diet. I don't think they have to worry about doing a low protein diet in early stages at all. It will not be preventative in any way because it's not the protein you're eating, it's your kidneys not being able to process the protein. Right now, when people actually end up going into kidney failure, the nephrologist might make recommendations on certain diets, but that's more when you're in kidney failure. There's no reason that you'd have to do a low or high protein diet. You would have to modify for lupus nephritis otherwise. Great question. We had some questions in the back.
Do. So you spoke about combination treatment like Celsep, Plaquenil, and prednisone. So if a patient had already continuously taken that for years, what would you typically recommend as the next treatment if it hasn't been successful?
Yeah.
For like the
Great question. So when I'm referring to combination therapy, I'm not referring to the Plaquenil and prednisone, which patients would be on. It would be Celsep plus another drug. So it'd be Celsep plus Benlysta, Celsep plus voclosporin, in addition to the prednisone and Plaquenil. But it just depends on the patient characteristics. So some patients, if Celsep is not enough, will go to cyclophosphamide. Some patients, if the Celsep has helped, but it's helped but not 100%, we'll add Benlysta or we'll add voclosporin to it. And it really depends on the patient's interest and ability to take more pills, because it is a lot more pills if you take voclosporin versus if they prefer an injectable to do at home or an IV, they would do Benlysta. There's other things in their blood work and in their urine that helps us guide the patient on which one might be a better option for them.
I see.
Right?
if
But it's
they're-
either Benlysta or voclosporin addition, because we've been doing the Celsep with the prednisone and Plaquenil for years. Now it's maybe Celsep needs something with it to actually have better efficacy.
Gotcha. Thank you.
Yeah, absolutely. And I think I had another question in the back. Yes.
Two more. One here.
Yeah, perfect.
Is there a second best treatment after Plaquenil?
For prevention,
Yeah.
so Plaquenil is the only one that's preventative. But we have Celsep, we have cyclophosphamide, we have Benlysta, we have voclosporin. Aside from Celsep, there's azathioprine that if people can't tolerate Celsep, they can use that as well. And I would consider that, a second best therapy to Celsep.
Okay, and the side effects of that would require that you have involvement.
No, these medicines are also used for other lupus involvement as well. A lot of the medicines I'm talking about, like for example, Benlysta, was first FDA approved just for lupus, not lupus in the kidneys. Azathioprine, which is Imuran, is used for lupus as well as lupus in the kidneys. Celsep is used for lupus in the kidneys, but it can also be used for lupus as well. So all these medicines I'm talking about can actually be used for generalized lupus as well.
Okay.
They're not just specific to lupus in the kidneys, but the focus of the talk was lupus in the kidneys, so I was talking about the therapies that we try to focus on when people have kidney involvement.
Thank you.
Yeah, absolutely.
I'm going to do one more.
Yeah, of course.
First of all, Doctor, beautiful presentation.
Okay,
Thank you
thank
for
you.
all the
Yes,
information
of course.
that we may have heard, but you just clarified it really well. So
Good,
thank you for that.
good.
I have two
Fine.
quick questions. First question is about the cyclophosphamide. You talked about how pregnancy in women don't hear too much, but does it affect men's sperm count?
Yeah, it's a great question. It can, but not sufficiently so that we worry about it. So it's okay for our male patients to get. It's more for the female patients that it causes the ovaries to fail, if given at a later age.
So having
That's a great question. Yeah.
having SLE and lupus nephritis,
Yeah.
more blaming it on SLE.
Having SLE and lupus nephritis, blaming what on SLE?
Well, no, I was asking because, unfortunately, I was
Yeah.
told years ago that
Yeah.
I had zero due to lupus. But after
Oh,
talking
I
and hearing
see.
about
Yes, great
I'm just
question.
wondering.
That's what you're wondering. I'll have to get back to you on that. Then I do wonder if it might be more, it could be a little bit of the combination of the two, but I'll definitely get back to you on that.
And then the second question just had to be with having SLE and lupus nephritis, kidney involvement, then having a transplant. Is it more likely?
Oh, it's a great question. And I think my nephrologist, my transplant physician who's coming will address that as well. When patients have a transplant, there is a chance of lupus coming back in the transplanted kidney, but it's very low. So honestly, in 18, 20 years, I've only had one case of that ever happen, right? So, but that I've seen. I'm just saying, right? So it can happen, but it's not very common.
Thank you so much, Doctor.
Great question.
Thank
of
you,
course.
Dr. Desai.
Yes.
So we just want to let everybody know in the room and online, if you have questions for Dr. Desai that you'd like answered, please send them to info@lupusla.org, and we'll make sure that she gets them. I'm excited to introduce our next speaker. She is a licensed psychologist and a lupus patient. She is also a member of the Lupus LA Medical Advisory Board. Please join me in welcoming Dr. Monica Blied.
So today we're going to talk about medical self-advocacy. How can you, as a lupus patient, advocate for yourself when you're going to see your doctors or nurses for your lupus, or because of other things that we have going on? Where's the clicker? Things that we have going on with our lupus. Thank you so much. Thank you. So here's the agenda. I'll share a little bit more about myself and then share why do we need this conversation? Perfect. And talk about some of the research that came out just last year about what happens when there are diagnostic errors, what happens when there is stigmatizing language or bias that we receive from medical providers, and what can we do about it. So we'll talk about that. And I'll go point by point by point on things that you can do on your own and with your support network. And we'll have time for questions at the end as well. So a little bit about myself. As Susan said, I am a lupus patient myself and a clinical psychologist here in California. I'm in Claremont specifically. And the first part of my career, I spent educating medical staff, so physicians and nurses and dietitians, on patient-centered communication and how to have the most productive appointments when they are with a patient who maybe has a lot of questions or doesn't understand their disease, and not making assumptions about any of those patients. So that's the perspective that I'm coming from. I'm coming from the perspective as a professional who has helped to provide that training to medical staff, and as a person who has lived with lupus since 2012. And later with fibromyalgia, and then later with chronic migraines, because you just can't have one chronic illness. and telling about my experiences as a patient as well. Why do we need this conversation? So we just had a talk by Dr. Desai, and we heard about this fantastic whole health system of care that you can get at UCI. They also have similar systems of care at UC LA and Loma Linda University, but that's not always the care that we receive. How many in this room or online have ever been to an appointment and felt like you were rushed? Nearly everyone. Or felt like, you, maybe there was enough time, but it was right after you left that you're like, oh no, I forgot to mention this particular thing. How many have ever not been believed when you shared about your symptoms or about your pain? That's what we're talking about today. When those things happen, how can you show up for yourself? So Dr. Perry Wilson at the Yale School of Medicine published a study just last year where he looked at the charts, his team looked at the charts of over 2,300 patients across 29 hospitals. And what they found was, and they were investigating the connection between stigmatizing language written in those medical charts and diagnostic errors. And what they found was that when there are phrases that questions the patient's credibility, so that like medical gaslighting type thing where you're not being believed, and it doesn't have to be something as egregious as this patient is medication seeking, just trying to seek pain meds. It can be something as subtle as this example here. He claims the nicotine patches don't work for him. He claims, instead of saying the nicotine patches did not work for this patient. So even those subtle things are an example of stigmatizing language, and such language does impact diagnostic decision making. Of if you're going to be diagnosed with the correct and most accurate disease or disorder that actually explains your medical experiences. So what the study found was 23.2% of patients did have diagnostic errors, 5% of records had stigmatizing language. So that's a low percent, but if you're within that percentage, if you're within that 5%, it makes a huge difference. And of those that had stigmatizing language, they were twice as likely to experience diagnostic errors. And so if there's an error, that means you're not receiving the right treatment, which means your disease is going to progress in a way that is not good for you or for your family members who are relying on you, and those sorts of things. Stigmatizing language was more common if the patient was African American, if they had unstable housing, if they also used public insurance, so Medi-Cal, Medicare, those sorts of things contributed to these patients not being believed, and the expression written in their medical records being stigmatizing. This is a real world example. Who recognizes this person? A couple people. So this was a makeup influencer, and she passed away last year after over a year of trying to get treatment and knowing that something was wrong and going to the doctor, going to physicians and not being believed. By the time that she was finally diagnosed with cervical cancer, it was too late. What the news shared was that with these appointments that she was going to, no one actually did a physical exam. And so by the time someone went down there and looked at what was going on, they could not believe that there was actually a prolapse within her vaginal area. It was so obvious that there was something very, very wrong, and unfortunately, this person died. This is something that is not common, but again, we want to prevent this. If the knowledge is power, and so if you have the information that I'm going to share today, if you have a support system around you that can prevent those sorts of things, someone who can help to advocate for you, whether it be through Lupus LA or Patient Advocate, and I've shared those resources in the online packet that you all will get, a list of patient advocates and directories. Whoever that is, it's going to help to save a life. If not yours, then maybe a friend of yours. So, what can you do? Number one, and I want you guys to write this down, is to check your charts. Check your medical records and see if there is any sort of stigmatizing language that is present. See if there is any this person claims, or anything that isn't actually accurate to your experience or accurate to what happened within those medical appointments. And what you can do is actually ask for your records to be revised or for sections of your records to be redacted. So I have a therapy client who has multiple chronic illnesses, and because of that, she's had to go to the emergency room to address things that come up emergently, obviously. And one of the physicians that she saw just was not believing the amounts of pain that she was in, or her statement of, these are the pain medications that work for me, and these are the pain medications that I've used before that do not work for me. I've been chronically ill since I was 14 years old. I'm 34 years old now, I know what works and what doesn't. And so she went and checked her medical records later and saw that doctor had actually put in her records that this person was really hostile and possibly on a bipolar manic episode, and all these things. Yes, this client of mine, this patient, does have bipolar disorder, but they weren't manic. And so, those sorts of things, it's really heartbreaking when it happens. But if she hadn't gone back and looked at her records, she would have no idea. And what happens then, if that kind of language is put in and that kind of bias is not redacted or corrected, is that the next person who sees her for care is going to approach her differently, because they're like, okay, this person is, going to be hostile. This person is not going to follow medical directives and that kind of thing. And again, that can lead to less than ideal care. And when you do ask for your records to be redacted or revised, make sure you document, keep a written record that you made this request. The date that you made it, who you talked to, whether it be the patient services coordinator or whoever that is. Stay organized during your appointments to kind of prevent some of the things that could happen where you are rushed or not believed. Stay organized. And this is actually what I would recommend to the medical staff is when you come into your appointment, I know that, there's so many things that you need to go over. You need to go over the patient's labs and ask their current functioning, and you have a checklist. Let that patient know the agenda for the day, and then ask, are there one or two things that you need to add? That's what I'm teaching the medical providers. You as patients can do the same. Make sure that you're writing down, these are the things, doctor, nurse practitioner, PA, these are the things that I would like to talk about today. And have 2 to 3 things written. Don't have 15 things written because there's not enough time for that. So we still want to have that balance in respecting the time frame that is allotted. But have 2 or 3 things written. And the benefit of that is, one, you'll remember the things that are most important to you to bring up in that appointment. And also, it brings in a spirit of collaboration between you and your medical team. And it's just going to make for a much smoother experience within the medical system. So here's an example. I know we're here to discuss my labs. I was hoping to also review my medications, my pain level, and some other questions that I brought for you. And where should we start? Why would you ask that question? Anybody? You here in the green. Yes. Why would it be a good idea to ask the question, where should we start?
I would ask where will we start, because the doctor might have a place in their head where we can start, and then as we continue to talk, then we can move into my concerns and questions.
That's exactly it, and I like your twist too, sis. That's exactly it. So, the doctor may already have a plan and agenda, and so again, we're trying to invite the spirit of collaboration within that appointment, and that's just going to help with that. And it also establishes, these are the things that are important to me, so let's make sure that that happens as well. Okay, so you are advocating for yourself in those ways. Again, helping you stay organized, making sure that the doctor doesn't miss any of your important concerns, and it reduces the chances that you will be rushed or that things that are most important to you will be ignored. Support system. I cannot emphasize enough the importance of having someone with you. Number one, when we go into these appointments, especially if it's a new diagnosis or new symptoms that are coming up, there can be a lot of stress. And as a psychologist, this is really my area of specialization, is the impact of stress on our brain function. And what happens when we're under stress is our limbic system here, I'm pointing to my ear, temper in our temporal lobe. Our limbic system is activated, our emotion system, and it's like fight, flight, freeze. And we may freeze and not say the things that we need to. We may maybe be a little bit more, I don't want to say aggressive, but more to the point than we mean to be, and not have that collaborative tone, or so many other things. And what it actually shows in MRI studies is when we are under stress, there is less blood flow to our frontal lobe. Our frontal lobe is our rational thinking, our problem solving, our sense of collaboration, our creativity. All of that is out of the window. And also our receptive memory. And so if you're getting information from your provider about, this is the medication, these are the choices that you have, these are the side effects, you won't even receive it. And so one of the things that helps is having a second person. They can help to remember the things that the physician or the medical team is telling you. They can help you to stay on track with the things that are most important to you, and making sure that you ask those questions. And also they can help to also document later if there was an interaction that demonstrated that there was some bias there. Not everyone has a family member or a friend or a spouse or a partner that can come with them. So what do you do in that case? In that case, there are individuals who their job is patient advocates. And so there are patient advocate networks. My friend Emmett here, he has his fiance, and she's the advocate, and then they're both for one another, and they're both living with lupus. But not everyone is as blessed, right? And so you can, especially if you have Medicare, which a lot of individuals with chronic illness do, it's completely paid for, where that person can either physically come with you to your appointments or FaceTime or video in to that appointment while you're there to make sure that that medical provider is explaining things in a way that makes sense, making sure that you're staying on track with getting your questions answered, that you're not being rushed, and that if there are any concerns, that they are addressed within that appointment time. And so it's not on these slides, but again, within your electronic resources, you're going to have a whole list of patient advocates. And that same patient that I told you about who had that bias in her medical record that was just egregious, she now has a patient advocate. The patient advocate happens to have her same first name, and they're like best friends. And this patient advocate is all the way across the country, but still comes to every appointment, goes to every emergency room visits, and we'll ask like, okay, well, why are we choosing this treatment over that one? A lot of the patient advocates will have a medical background, or at least a nursing background, and be able to kind of speak that language with the medical provider. So you've done your due diligence. You've done everything that you can. You brought a person with you, you wrote down an agenda, you tried to get your concerns addressed, and you still feel like every appointment is 3.5 minutes or less. You still feel like you're being ignored and dismissed. You still feel like your questions are never answered. Or, something that happened to me, unfortunately, I was prescribed a medication, not explained any of the side effects, had terrible side effects, literally like hallucinations and word finding difficulties and all these things just with one pill. No response by email from the doctor. This was on a Friday. No response from the clinic when I called on Monday. Ended up having to go to my primary doctor and get on a course of prednisone to calm down the inflammation. Like, these things happen to us. And so if that happens, what do you do then? Change the doctor. And it seems simple, but sometimes we can still feel stuck, like we don't have any other choice, especially if you live in an area where there's only, one rheumatologist within 100 miles or something like that. Sometimes we can still feel really stuck. But remember, you are paying for a service. Even if it's your insurance that's paying, you're still paying for a service. So you should get quality service. You should be listened to. You should feel heard and understood. And if you don't, then it's time to change it up. So finding a new provider, make sure that you request documentation of refusals. And so if you are saying like, hey, I know my labs look normal, but I'm still feeling joint pain and severe fatigue. I can barely, get through the day, let alone trying to cook dinner at night. Like, I still have all these clinical symptoms. I would like to try Benlysta. And your doctor's like, no, I think you're fine. Like, your labs are fine. Like, has that ever happened? Like, your labs look fine. You're okay. Like, no. I'm telling you about my experience. If you still feel that, and someone is saying like, no, I will not give you this care that you're requesting, make sure that you ask, please document on my medical chart that you are refusing this. And then just watch how the conversation changes. Well, maybe, let's talk about some alternatives. or even let me explain my perspective on why this isn't the best medical decision for you at this time. The conversation opens up, but be sure that you ask any refusals to be documented, and also ask for something called a differential diagnosis. And so if you are having new symptoms, unexplained things, and they're saying like, okay, this is this disease, okay, well, how did you come to that? Explain your differential. Differential basically just means, why is it this disease and not this disease or this one? Why is it, like our last presentation, why is it, lupus nephritis and not diabetes, or not a combination of them? And make sure that request is documented as well. And be sure to clarify any confusion. I like Dr. Tassari, I think her name was on the last panel, said, if you don't know what they're talking about, if they're using all this jargon, or there's a new medication and you're not sure why you're being prescribed it, or how it works, or what are the side effects, ask. And make sure that on your list that you brought, you make sure to have that question mark of, ask about this medication. Ask, when is the best time to take it? Because for some, it's better to take it at night versus during the morning. So asking those questions, clarifying any confusion. Making sure to ask about risks and benefits, side effects, potential benefits of treatments, the request of the differential diagnosis. I talked about that before. And remember again, you're paying for a service. They're not doing you a favor by providing you medical care. And sometimes we can feel that way, like, okay, well, I don't want to say anything, and we can feel really, really small because there is this power differential between yourself and the provider. However, as Dr. Desai said, you are the expert on your own life. You are the expert on your body. They are the expert in medicine. And so you collaborate together to make sure that you're getting the best care that you deserve. You deserve good care. Okay, so as takeaways and summary, you can be your own best advocate. Make sure that you have a support system. Speak up for yourself. This can be very scary, especially if that stress system is happening in your brain. So sometimes you just have to pause. Excuse me just 1 second. And let them see you take a deep breath. Okay? Because there's something called neuroception, where what one person is experiencing internally, the other person will experience as well. And so if they see you taking a deep breath, their mirror neurons in the brain will have them take their own deep breath. Both of you all are now more calm, and you can have a productive and collaborative visit at that time. Don't be afraid to request changes to your medical records, revisions or redactions. Ask for clarification. Fire that doctor or change providers if necessary. Have that clear agenda for your appointments. Again, 2 to 3 main points that you want to talk about. Write down your questions, bring a support person, even if it's the patient advocate that is, pretend this is a phone, even if it's a patient advocate that is via telehealth, making sure that you have that second set of ears, second set of eyes. And remember, you deserve respectful, high quality care because you exist as a person. You do not have to earn it. You deserve it. And by advocating for yourself, you can help ensure a better outcome in your healthcare journey. Questions?
Thank you so much.
Okay, I'm going to take one back here, and then I haven't missed those in the front. Hold on.
Thank you, Dr. Blied. Very, very informative again.
Thank you.
I more have a comment in regards to what you said. I like the fact that you talk about advocating for yourself, and that's what we should all do as patients. But it makes a big difference. It's also your word language to the doctor. They cannot treat us based only on what they hear from us in a minor way. We have to really explain what is really going on so more action can be taken.
Yeah.
You know, we can advocate all we want, but if we're not finding the right words to use, the doctors can't read our minds. You know, sometimes what comes out our mouth may not be on our mind. So it's very important with that, the way that we feel. We want action done, but sometimes the doctors feel that no need to be done the way that it was explained of what's going on with you. So thank you for opening that up for me.
Yeah, thank you so much, Emmett, about we have to kind of use the right words, use the right language, and one of the ways you can do that is by symptom tracking throughout the month in between visits. So, you know, especially with lupus being so variable, sometimes you're okay and sometimes you can't get out of bed, making sure that you write those things down and having someone that you can bounce ideas off of how should I present this information? How should I present this ask to my medical provider? And that's where the Lupus LA support groups really come in handy, and you can join the support group from anywhere around the world to be able to talk to other patients just like you who may have a story and may have an experience of, okay, when I told the doctor that I was just not feeling well and feeling sluggish, they dismissed it and minimized it. But when I said I have severe and impairing fatigue, they perked up to that and tried to address it. So again, finding that language, connecting with the support group so that you're not alone and you have the right words to say.
Dr. Blied, we have a question from somebody streaming in. If you're rushed and you don't get all your questions answered, and the doctor says that you can only ask 3, how do you advocate for getting the rest of your answers?
Yes, so that was, Dr. Sandhu is next. That was one of the recommendations that I had is just having a few questions. So you may have to prioritize and space them out over a few visits because again, if you have 15 questions, the medical provider is limited with productivity measures that they have and how many patients they need to see in a day and those sorts of things. So we're trying to find that balance of I still need to get my needs met and we have 30 minutes or 15 minutes, whatever the case might be. So it's about prioritizing.
Yeah, right here, and then.
Hi, real quick, I have a comment. Thank you so much. Your presentation was awesome. I'm speaking for my daughter. We have had on many, I shouldn't say many, I can think of 3 occasions where the information in her medical record was incorrect. She'll say, Mom, it'll say no pain. And she goes, Mom, I went there because I was in pain. I told him I was in pain. So therefore, I'll give you just one quick example. She spoke up and it was the chairman of rheumatology. And when she went back again, it was another doctor, but she says, Mom, they dismissed me. I could just feel they didn't want to see me. So thus we changed doctors. Went to another doctor, a rheumatologist, prominent. Her medical record was so messed up, they even had the wrong name. So goodness. Because she's had to go to different medical groups, her records are all over the place.
Yep.
And so therefore, I found an app. So this is my question. It's called One Record.
Okay.
Do you have any comments on that?
So I'm not familiar with One Record. When that has happened in the past, I have clients or patients who will literally have their medical records and they will bring them with them to the appointments or even to emergency room visits. But I love that now you can do that electronically. I am so sorry that happened. Unfortunately, it is way too prevalent, especially with Black women, and their pain being denied and dismissed and minimized. And so what I would recommend, even for those records that you already have that you're moving on to the next person, is making sure that you ask for them to be revised. Because actually on that appointment, I said my pain was a 7 out of 10 and not 0. Making sure that's revised and documenting when you ask for that revision, and if that revision is denied, documenting that as well. And keep in mind that all licensed practitioners, including myself, have a higher authority that we have to answer to. So, you know, there's a board of psychology. For me, there's a board of medicine for physicians. Everyone has someone that they have to answer to. And so if you're pushing and you're advocating and you're still getting that dismissal, then going to that next step.
Hi. Well, good morning. My name is Dr. Carla Lewis. I'm also a licensed peer educator, and I work with chronically ill patients with lupus and cancer because I have lupus and I have stage 4 breast cancer that I'm battling. What I tell my patients and what I advocate for friends and family, whoever, I always tell them, as piggyback on what you said, when some patients don't have time to get all their questions answered, what I always recommend is schedule an appointment. This is why now we have telehealth, and you don't have to pay for that through your insurance. That's the free service through all insurances. So if you feel that your answers or questions not being met, hey, send an email. I would like to schedule an appointment. Are you available? And then you give your doctors or practitioners dates and times. Just don't say, can I meet with you? Hey, listen, I'm available Tuesday, Wednesday, Fridays. Between these times and these times, I would like to have a team conference with you to discuss additional questions that I may have that I was not able to have that when I saw you on February 5th. Also, what I tell patients as well, with lupus, we have other doctors that we see besides rheumatologists. So what I tell doctors, schedule a team meeting with all your doctors. Do a team meeting. I do them with my doctors every quarter. So every 90 days, everyone has to be on that Zoom conference call, because I don't play that. Everyone has to be on that Zoom conference call. And if you can't make it, then I usually send out what I call progress notes. Or I send a note to that doctor who couldn't make that meeting to put them up to speed, because the worst thing is that you may have an ophthalmologist, you may have a diabetic doctor, you may have a dermatologist, rheumatologist, oncologist, and no one knows what A, B, C, and D is doing.
Right.
So it's always best to do quarterly conference calls, Zoom, telehealth, and say, hey, I need to meet with everyone before my next appointment with this doctor so that we're all on the same page. So that's some advice that I advise everyone in the room to think about and do, so that you don't have to feel stressed out when you go for your appointment and you didn't get all your answers worried.
Yes. Thank you so much, Dr. Carla. That is such an important point, that we have coordination of care. And so that's why I love, like, at UCI, where there's a system of care, where people, the medical staff are talking to one another. And I'm so glad to hear that your providers agree to get on those conference calls, get on those Zoom calls, and make sure that you're getting the best care. If you can, please do that. Unfortunately, sometimes we have, one provider in LA and another one in Central California and another one, in Claremont, that's where I'm from, and so it's a little bit more difficult, and they're from different health systems. They're not talking to one another. But if that is the case, then something like that electronic medical record where you can say like, hey, this is what has happened with my other providers since I last saw you. I would love if you would review this before we meet.
I'm going to take one more question in the room.
Yeah.
Hi, I'm one of the older people here, and so a lot of times when you go to your doctor, after you see the doctor, they say, okay, here's your next appointment, and they'll just give you a paper for your next appointment. But if you tell them that I can't remember a lot of stuff, so I need you to print out all the documentary, everything she said, they will give you a printed copy to take home, and you can read it over later.
Yes.
And I'm with my chart, so I can go in my chart, any questions I have, I can go type a letter to her, and she can read it later and text me back the answer.
Yes, so you're talking about discharge summaries. So ask for a discharge summary. That's not just for if you go to the ER, you can get it for every visit that you're going to. Sometimes it's not immediately available because they still have to, write their chart notes, but still ask, like, okay, if you're doing it at the end of the day, making sure that their office staff can send it to you at the end of the day so that, again, like you said, you can go home. Is that Jane, Joan, yeah, Miss Joan, so that you can read it that evening and you're not relying on your memory. And keep in mind that our brains have a lot to hold. And so if you can, even record your visit on your cell phone using the audio recorder, or type notes while you're there, write down notes, so that, again, we're not relying on our brains to remember when we can't really do that if we're under stress anyway. Okay, thank you all.
All right, so this is me, just very briefly. I'm a rheumatologist by training. I was previously at Loma Linda University, practicing as a rheumatologist and teaching. I was leading the fellowship training program there, and made the jump over to Fate Therapeutics, where I currently lead their clinical development program in autoimmunity. I'll be talking to you a little bit about our clinical trial that's currently ongoing, but really just want to give you an overview of cell therapy in SLE and give you a big picture of it, and then delve a little bit more into our study. So full disclaimer, I am employed by a biotech company that is doing a cell therapy study in SLE. So let's start very, very high level overview on what causes lupus, and you've probably heard this before, but just the key contributors of developing SLE range from genetics, so what's in your genes from family actually ends up being a very small percentage of that risk of SLE, certainly increases with having a sibling with SLE or twins, but it's also having a defective immune defense, your environmental exposures. We talk a lot about UV light, there's hormone relations, and a multitude of other things that we talk more and more about. Pollution and the impact of SLE. There's something called epigenetics, which is where your environmental exposures will affect your genetics and that risk related to SLE. There's also antibodies, and that's the most relevant thing for this talk today, because the treatments that we currently have in lupus tend to be broad-ranging, but there's this concept of B-cell specific therapies where we're trying to target antibodies. And in lupus, there are antibodies that are associated with causing inflammation and damage in the organs, the tissues, skin, kidneys, and so on. So those antibodies come from B cells. And at the bottom, just showing you this lifespan of a B cell coming from the bone marrow. We have pro B cells and really progressing over into the periphery where you're starting to see these memory B cells, plasma blasts, the plasma cells. Autoantibodies, double-stranded DNA, Smith as a couple of examples, these come from these mature B cell stages. And that's where this concept of CAR T-cell therapy comes from. So similar to, I'm sure, how many people in this room, and I'm sorry for our online group, but raise your hand if you've heard of rituximab or Rituxan. So Rituxan targets B cells, and B cells are the antibody-producing cells. CAR T cells are a type of cell therapy where the T cells are trained to be fighter T cells, and they target, in this case, B cells. They can have a variety of other targets, but in this case, B cells. And for B cell cancers, in this specific scenario on this slide here, there are a couple of FDA-approved treatments that are just listed here just as an FYI. There are these autologous, so auto CAR T-cell products, and I'll go into a little bit more detail on what that is, that are FDA-approved to treat B-cell malignancy. And here it's listed as Kymriah and Yescarta. Just on the right is the Michelle Satterline paper that talks about CAR T-cells in B-cell cancers. So that information kind of triggered this series of discussions on, well, we know lupus has a huge B-cell association on what causes SLE, so why not use CAR T-cells in SLE? So this paper comes from 2022. Dr. Georg Schett and colleagues, this was published by Andreas Mackinson and his colleagues, but looked at 5 patients with lupus. They had moderate to severe disease. They had tried multiple therapies already for their lupus and still continue to have active disease. And just showing you here on the bottom left, they received a B-cell depleting therapy, so CD19 targeting CAR, that cell therapy, and I'm kind of using all of these terms interchangeably, that therapy significantly reduced their B cells on the far left. There we go. And then on the right here, we're just showing that those double-stranded DNA, the dsDNA antibodies, significantly dropped within 3 months of getting the CAR T-cell therapy. On the right here, this is just showing the lupus disease activity score, so a combination of physical exam findings, so symptoms, and also lab test results that showed that their lupus disease, each of these high markers are patients, so 5 patients, their initial lupus disease activity was high, and then right next to it at 3 months, just showing the ability of this cell therapy to drop down that disease activity. This is where the craziness started on cell therapy in lupus. We have a product that could potentially cure these patients. And so when I was still seeing patients, I was being asked, when can I get a cure for my lupus? I was a skeptic. I was kind of like, there's 5 patients. You need more data. And that statement still stands. We still need more data. This was published this past year. An update on the initial 5 patients included 3 patients with lupus, included patients with myositis and scleroderma as well. Similar reports that consistently this cell therapy is showing the ability to put these lupus patients into remission. Their disease is no longer active. They're being taken off of their treatments, so no more mycophenolate or Cellcept or methotrexate, whatever additional background therapy they were on. Similar responses in myositis and scleroderma, so reduced disease activity. So the other thing with these auto CAR T-cell therapies is they require a combination of cyclophosphamide and fludarabine. So they get chemotherapy as a pretreatment because that's standard practice for CAR T-cell therapy. So remember, this whole treatment paradigm comes from the cancer world. And in cancer, these patients get a combination of cyclophosphamide with fludarabine, which are both cancer agents that are used as what we call pretreatment or preconditioning for a variety of reasons, but it's really intended to, the simple way to say it is to make space. We don't fully understand in the autoimmune disease world what that actually means. But what we do know, so CAR T cells in oncology, in general, and very, very relevant to this group of folks here today and online, safety, because everybody wants to know, is this something that I can safely receive? What are the safety concerns related to it? In oncology, the safety side effects that are unique to cell therapy are neurotoxicity and inflammation. So what does that mean? Typically, you might hear the term CRS thrown around, cytokine release syndrome, and that's like having an immune reaction to the cells. So you get a cell therapy, and then you develop fever, low blood pressure, the blood, the oxygenation can drop. So it's kind of like having a hyper-inflammatory response in the body. The CAR T-cell therapies in oncology all include a preconditioning therapy, which is what I mentioned, that chemotherapy that's given prior to getting the cell therapy. We know that that's required for these chemotherapeutic indications, but now as we're moving into the autoimmune disease cell therapy space, we have seen across the board less neurotoxicity, less of those CRS or inflammatory cytokine release syndrome events. And the chemotherapy requirements are not yet clear. In rheumatology, we're not familiar with giving fludarabine, bendamustine. Has anyone here not heard of cyclophosphamide or Cytoxan? All right, so there are still some. So Cytoxan is considered a chemotherapy, but it is used for severe active lupus where your organs might be affected or you're at risk for organ damage or at risk for dying. And that's kind of the very, very sick in the hospital. We don't know if this is going to result in, I'll just use the kidney as an example, this patient may end up on dialysis, or there's a ton of other things going on, we need to give them Cytoxan or cyclophosphamide. So it is a little bit more of an older, more traditional approach to treat lupus, but it's still used quite a bit in patients who have active, what we call organ-threatening lupus. We don't know what this chemotherapy requirement is in the cell therapy and lupus world. So we know that a limited number of patients with autoimmune disease have been treated worldwide with cell therapy. And we know that autoimmune disease is different from cancer, so we don't really know what the rules are just yet. And I'll show you in the coming slide what the stages of drug development are, because generally speaking in lupus, patients are more familiar with a phase 3 clinical trial where you're put into, I'll just use the most recent FDA-approved therapies for lupus, like Benlysta, or Safnello, or voclosporin. These are the more recently approved meds, and most of the patients that were plugged into those clinical trials more recently was at a later phase. Cell therapy is really in a phase 1, phase 2 clinical trial stage right now. So phase 1 is really testing the safety and the amount of drug that's present in the blood of patients who get it. So you come in, you get the treatment, and we're testing, is it safe? Are you tolerating the amount that you're getting? How much are the B cells coming down? How much of the drug is present in the system? So it's a very early phase, and we are seeing some phase 2 clinical studies as well. And that tends to look more into, is the disease getting better? The difference in why there's so much excitement about cell therapy is even though it's really only a phase 1 or a phase 2, we don't typically look at remission in these early phase clinical trials. In fact, in lupus, the term remission is not used so lightly. It's pretty hard to be in remission with lupus, and we're seeing that with cell therapy. And while it may really be specific for a unique group of patients, and I'll go over that, the fact that we're seeing that really creates a pathway for, can we get to market earlier? So that's why I wanted to show this to you. The current clinical trials in phase 1 and phase 2. Phase 3 tend to be these larger studies where there's a control group, and a control group is where it's, how many folks have heard of the term placebo? A lot of the sham, there's kind of multiple different terms that are kind of used, but placebo actually means there's one group of folks that will actually get the drug under study, and then one group of patients that will not get the drug under study. And traditionally in lupus studies, you have that you're not getting the drug under study, but you're going to stay on your background medicine. If it's Cellcept or Myfortic or methotrexate or whatever else you're on, Benlysta, you get to stay on that, but you're not getting the study drug because it's the placebo. On the other hand, in this side, you'll get the drug and the whatever background therapy. So that's just traditionally in lupus what these clinical trials look like. Cell therapy is currently here. So we're still early, we're still getting more data. So again, I gave you full disclosure, I work for Fate Therapeutics. So this slide is differentiating auto CAR T cell studies from Fate's iPSC CAR T cell study. I'll explain to you here what that is. So in auto CAR T cell clinical trials, there's a process of a patient is screened, a lupus patient is screened, they're identified as somebody who could qualify for a clinical trial. They then have to hold whatever medicine they're on. So if you're on Benlysta or Safnello or whatever other medication you may be on, you have to hold it for a certain period of time, and then your white blood cells are collected through leukapheresis. And this is a little bit like a dialysis machine. The blood cells are taken out, they're separated, the T cells get isolated, and there's a whole process. I won't bore you with all of it, but there's a process where those T cells then get manufactured, and I'll show you the process in that regard is similar to what we do, so I have a more simplified explanation of it. But this process takes weeks before those T cells are genetically modified into fighter T cells. Those then get infused as an IV treatment back into a patient. This process overall, we're looking at anywhere between 4 to 8 weeks from the time of identifying a patient. You got to hold your meds, the sample's taken, it's manufactured, processed, and then put back into the patient. Fate's off-the-shelf iPSC-derived CAR T-cell therapy clinical trial is essentially bypassing all of this processing that I've described to you here. There's no leukapheresis, there's no additional blood collection and processing time. As long as a patient has been identified, you don't have to stop your treatment until just before entering the study. So if you're on Benlysta, Safnello, or any other medicine that you're on, it's held just prior to entering into the study. And then and then you get the treatment infused. This is the process by which the cells are made and what they're doing, though. So we have a healthy donor from whom we isolate their T cells. So we take their T cells out from a healthy non-lupus patient, and what we say is we de-differentiate them into stem cells. So it's taking someone's healthy cell, taking their T cells, converting it into a stem cell, because stem cells have this way of being able to grow and expand. And then we plug in a new receptor, which is the CAR. And the CAR that's plugged into that T cell, it has the ability to target B cells. So in this case, it's a CD19 targeting CAR. And that's what that is. That stem cell now has an edit plugged into it so that cell is only going to target those CD19 positive B cells, and B cells are the ones that make what? Antibodies. So you now turn your stem cell back into a T cell, and all of these T cells are now fighter T cells that are programmed to fight those B cells that have a CD19 positive expression on them. So those fighter CAR T cells find the B cells, and they remove the targeted B cells. All right, so that's big picture of auto CAR T cells, Fate's iPSC CAR T cell program. And then the name of our study is FT819102. The product is called FT819. That is a CD19 targeting CAR T cell product that has been programmed with what I had just mentioned to you. So it's a CD19 positive target that's there. We are enrolling patients who have active lupus, severe active lupus. It's going to be defined by having a SLEDAI score of at least 8. We're looking at BILAG scores that allow us to be able to include patients who also have skin and joint disease, which is a new change more recently. But really any organ system except for the CNS. So if you have active ongoing neurologic or neuropsychiatric manifestations, that would be the exclusion. And the only reason for that is based on the data on having some of the cell therapies historically have had neurotoxicity that I had mentioned in the oncology studies. I can say that at Fate, this company has been around for now 18 years. We've now treated using the same platform that I described to you for these cell therapy platform that I described. We've been doing that now for about 7 years. We've dosed more than 300 patients, primarily in the oncology space, and 4 patients in the lupus space. But we've never seen any ICANS, so that neurotoxicity has not been seen in any of our patients. So back to the lupus patients. So severe active lupus, traditionally, just like any other clinical trial, they have to have failed to respond to steroids and at least 2 other therapies that they've been on for at least 3 months. And no pregnancy or breastfeeding allowed, at least for now, because remember, phase 1, phase 2 clinical trial, we want to be demonstrating safety and tolerability at this early phase. So the steps of the study are a patient will come in, they're identified, and they will essentially get plugged into 2 arms. Either you continue your background treatment, so if you're on Selcept or Myfortic or methotrexate or azathioprine, you can continue that background treatment, and then you'll get a single dose of FT819. Alternatively, if you're not able to tolerate those other treatments, or for whatever other reason, perhaps after discussion with your rheumatologist, it's decided that maybe cyclophosphamide would be better for you, then you get a single dose of cyclophosphamide just 3 days before you get the cells, so 3 days before you get FT819, you get your cyclophosphamide. And there's the alternatives of getting the combination of cyclophosphamide with fludarabine or bendamustine as well. As I mentioned, this is more traditional with the auto CAR T-cell studies in lymphoma. You get FT819 on day 1. You're hospitalized for 3 days. That was required by the FDA, which is a nice, actually, compared to some of the other studies that are requiring hospitalization for a couple of weeks. So it is a shortened hospitalization, but certainly it's still there, and we're working to get away from that. And then the follow-up is, for the first month, you're seen once a week. You're seen again at 6 weeks, 2 months, and then every 3 months after that. And the intention is to see how you are responding from a disease standpoint. Are you getting better? Are those disease activity scores improving? Is the protein in the urine improving? Because lupus nephritis is included in the study. It's not strictly lupus nephritis, but it is included in the study. So addressing the challenges or concerns, how many of you have heard of cell therapy? So if you haven't, that's okay, but there are a ton of clinical trials ongoing in lupus, specifically in cell therapy. So one of the biggest challenges now for me being on this side of the world and kind of being a sponsor running these studies is there are other programs, sites are signing up with other clinical trial companies, and so making sure that we get enough sites, which means getting enough patients enrolled in the study, because you need patients in order to show your product works. So we need to be able to get that. We have hospitalization is still a requirement, so nobody wants to leave their child, their family member, whoever you're taking care of, to then get hospitalized for 3 days. Certainly it's less than other clinical trials, but it's still an imposition, and that's challenging. Safety first, so we are keeping that on for now, but working through it. We're here today to educate doctors and patients, at least to know sort of what's going on behind the scenes, what is cell therapy, and what our clinical trial is all about. And then safety and response, as I mentioned, this is the purpose of a phase 1, phase 2 clinical trial, and we are really hoping to be able to continue to see positive responses. As I'd mentioned, we've dosed now 4 patients with SLE, and all 4 of those patients have demonstrated a positive response to treatment. Our first patient was in remission at 6 months, so we are seeing similar results to what has been reported in the literature. So I know I'm almost at time, but what's Fate doing differently in clinical trials? So we have uniform cells. I know some of the questions that come up on the autologous CAR T cells are the sample is taken from the patient themselves and being genetically modified and being put in, so you're getting your own cells back in, but it's with additional modifications that include, in some cases, a viral vector, right? So a little bit different process, but we have a very quality-controlled process where we know that more than 90% of what we are putting into our CAR T cells are being expressed in the right way, which is actually in comparison to what we see with the auto CAR T cells, there's a variability of about 20 to 40% of that expression of that B cell target on the T cells. So we have a quality-controlled process in place. You don't have to get leukapheresis. You're not having to be off of your treatment for a month before you get the product infused. And then you get to decide the pre-medication with your doctor or other healthcare provider that's managing your lupus. That's all I've got for you.
Thank you so much. Thank you, Dr. Sandhu. We're going to take a question or two.
Yeah. Sorry.
I also want to encourage everybody that's here in the room. Fate has a table out in the hallway to discuss their trial and sort of the parameters around that. So we encourage you, before you leave, to stop by.
Yes, I'm wondering with the off-the-shelf, is there a higher rate of an individual's body rejecting that since it's not their own cells being injected back in?
Wonderful question. So what we know is that unlike what we're seeing with the auto CAR T cell products, our product is actually not even in the bloodstream beyond 1 to 2 weeks, basically 8 to 15 days. So it's not really in there long enough to trigger that response out of the system before it's able to be fought against. So essentially what we look at from at a very deep cellular level is B cells coming down, and the B cells that are coming back up as naive B cells. So they are theoretically no longer expressing those bad antibodies that are causing the damage. That said, we know patients with lupus may have a positive double-stranded DNA antibody. That's something that's not always causing damage, but what we're seeing is that the B cells that are coming back are naive.
Thank you so much for this presentation. I have 2 questions. So the first, for how long is a patient B cell deficient in the process? And the second is about your trial, but also what you know from the other CAR T trials that have been done. Does the data yet discern between which biomarkers best respond to this treatment? So for instance, we know that lupus patients have there are so many manifestations of lupus, and there are multiple tests to diagnose lupus because there's no singular test, but rather multiple tests. Right. And there are a variety of autoantibodies. So most of us have a positive ANA, but then do we know, for instance, if patients with a double-stranded DNA versus anti-Smith versus antiphospholipid are responding to CAR T treatment?
Great question. So I'll start with the first one. The B cell depletion again, so for lupus specifically, I mentioned we've dosed 4 patients. I can tell you that the B cell, and again, 4 patients, so it's all dependent on how far out that data is available to disclose. But I can say that our first patient now, we're out to 9 months, but her B cell repletion, so they started coming back up within 3 to 4 weeks. So not very long. And so that's what we see as a perk of you get this, it's not the patient's cells, but you get this product, it's only in the blood for a couple of weeks at best. It does what it needs to do, it's out of the system now, and those B cells are coming right back up within a month of getting the cells. And then to speak to your second question about a biomarker, so biomarkers are often what we use to monitor disease response or disease activity, and if a patient's getting better. The quick answer to that is no. We don't have the answer to that just yet because lupus is so heterogeneous, right? No 2 patients with lupus are the same. Some will have mainly skin, some will have kidneys, some will have Smith and not dsDNA, and some will have the other way around. So I don't think we have that information just yet, but certainly we are seeing some reports of the antibodies being completely depleted from the system. The jury's still out on what the value is on that specific information compared to what we're seeing come back from the B cells.
Thank you so much.
Thank you, everyone.
Dr. Sandhu. Again, I encourage everybody to go out and go to their exhibit table, and you can speak with Dr. Sandhu and the FATE representative and learn, get some of your questions answered. Our next speaker is our final speaker. He is the director of UCI Health Kidney Transplant Services. When I wrote this last night, I realized that he's the only doctor here not on our medical advisory board, so we're going to change that. Please join me in welcoming Dr. Reddy.
Thank you for having me. Let me first find my slide deck here. Oh, that's me. All right. All right, so today's talk is a little bit different than probably what you've heard of up to this point. Today's talk is about my world, and I'm gonna have the privilege to kind of share with you the world of kidney transplantation. That might be, if you're in the audience, like something you're not looking forward to or something that seems scary, and hopefully with the treatment updates you got today, this is something you will never know or need to know about. But for some, this is, going to be a reality of a situation, and I hope you get, some hope and some inspiration and some knowledge about this awesome field of organ transplantation where we can continue life and health for our patients. So, yeah, so we'll start. So thank you. The outline today is very, laid back format. I'm going to just share with you just general information about kidney transplantation. I'm going to have a couple self-plugs about the UCI kidney transplant program. For anyone, that is going to be in need of something like this, I just wanted to share with what we're doing here at UCI. And then kind of loop it into lupus and what we see with the lupus patients who get a kidney transplant. So first slide is just to share with you that, kidney transplantation is something that is going to happen to people in this world. These are some celebrities that get kidney transplants. In 2024, we did 27,000 kidney transplants in the United States. And we continue to try to do more and use more organs, but patients continue to also have kidney failure. So Selena Gomez famously got a kidney transplant here, SoCal, she's lupus. George Lopez got a kidney transplant. Alonzo Mourning won an NBA championship after you get a kidney transplant. Yesterday, Nate Robinson, who was a former NBA star, got his kidney transplant after a long wait. And so these are just some, just to share. So that's how the kidney looks. It's like about the size of your fist, and we put it in the right or left iliac fossa. We don't take out your old kidneys, and that's how it looks as we take it out. So this picture shows your original kidneys. Is there a little pointer on this? Yeah, these are original kidneys that you're born with. And then those are kind of towards the back. But with the transplant, we make an incision on the front, right or left side, and we place the kidney into that space, and it works. It has one artery, one vein usually, and one ureter. We connect the kidney's artery to your artery, the kidney vein to your vein, and the ureter to your bladder. And you do this surgery, and right after that, kidney turns pink. And then you see urine being made. And it's the most dramatic, amazing thing that we can help each other with living donation and deceased donation to help someone suffering with kidney failure. And that's how the surgery looks, and that's in the operating room. So just a little bit about the surgery itself. The kidney transplant surgery usually is 4 to 6 hours. Most patients are hospitalized between 4 days and 7 days. Sometimes things can get complicated and it'll be a little bit longer, but on average, you can expect to stay about a week. In lupus, you use drugs to stop your body from attacking itself. In organ transplantation, we use drugs to stop your body from attacking the organ, because your body knows that that's not you, and every day that kidney's in there, you're gonna wanna fight that organ. And so we use oftentimes very similar medications that lupus patients use to essentially have the same process of suppressing the immune system. Hydration is very important after kidney transplant. For people that get a kidney transplant, we usually tell them that they're not going to be able to work for about 2 to 3 months, but we have patients that sometimes can work in 6 weeks or so. And then you'll have a scar in your lower abdominal area. And the kidney, again, is about the size of your fist, so if you can imagine how big the scar would be. We did 2 kidney transplants yesterday at UCI, and we have 2 today. We have a kidney coming in from San Francisco that'll get here at 3:45 for our first case, and we have a following that. We're going to have another kidney transplant as soon as that's done, so 4 to 6 hours after that. So 4 transplants in the last 2 days, and we continue to try to give people a chance. So at the time of the kidney transplant, you'll be given very strong medications, IV, to suppress your immune system with more like a stronger immune response. And then after the IV medications, you're gonna take oral medications every single day for the life of that organ transplant. And compliance is very important. So oftentimes, the lupus patients we find tend to be very compliant. They've been on immunosuppression before. They, unfortunately have progressed to kidney failure. And it's kind of the same thing after you get a kidney transplant. You have to be on these same medications. So you probably heard today about Myfortic or Cellcept, prednisone. That's 2 out of the 3 big immunosuppression medications that we give you that you are expected to take daily. So there's a lot of overlap between our worlds. What I tell patients that have kidney failure, you know, they're sad, like, why is this happening to me? How come me? And there's, you know, a lack of hope of, I just don't want to get on dialysis. And, you know, I try to give them a different perspective. In this continuum of time where people have had lupus for, you know, hundreds of years, we now have this new therapy of kidney transplantation. That the first kidney transplant was in the 50s. It was an identical twin where we didn't have the immunosuppression that we have today. So the twin was not recognized as not self. So it was one twin that had kidney failure and one twin that was healthy. He gave a kidney to his brother. It was the first kidney transplant in 1954. And that patient ended up living 8 extra years, which at that time when you had kidney failure, no one lived that long. And so that surgeon ended up winning the Nobel Prize, and that was the birth of kidney transplantation. So it's almost just a generation-old option that was not there years before. So there's 2 main types of transplant, either a living donor transplant or a deceased donor transplant. A deceased donor transplant means someone passed away, and then that person or that family decided to, you know, donate their organs. In the United States, if we did 27,000 transplants last year, about 6,000 are living and about 21,000 are deceased. And so we are trying to get the word out for people to be living donors, because there's a huge advantage if you get a living donor transplant in that you don't have to wait as long as people wait for a deceased donor, which I'll talk about. So we really want to promote living donation. At UCI, you know, we have 4 living donor transplants this month in February, and we want to continue to find living donors to help their family members, their friends, to get off dialysis. So why is kidney transplant so important? This is a very important slide because sometimes when you're put on dialysis, you know, it's like, okay, you just start dialysis, but it's a big deal in terms of your life expectancy. So at 5 years of people are on dialysis, more than half of them are not expected to survive. And it's pretty terrible numbers when you're facing dialysis. But if you get a kidney transplant, at 5 years, the survival rate's over 80%. And so, more important than anything else, getting a kidney transplant is very important to stay alive. So it sounds good, like just give everyone a kidney transplant. What's the, why not? Yeah. The problem is this organ scarcity. So I mentioned that we did in 2024 27,000 transplants. That was the most ever. We beat last year's record by 427. 27,000 transplants for a kidney, but there's over 100,000 people on the waiting list. And so this is the hard part. This is why finding a living donor is so important, because if there's this many people on the waiting list, the time to get that organ is very, very long. It's too long. And so this is the burden of my world, is we're not doing as many transplants as people that need it. And so how do we do that, right? How do we do that as a community? Now, the latest thing in my world is pig transplants. A few universities have tried experimental transplants where we use a pig organ. I don't think we're there yet for that to be the solution to this disease. But I do think that in America, there's 330 million people, and there's just 6,000 living donors a year. I think we can do something there. So this slide is just to give you a little kind of understanding of the world of organ transplantation. So this is just volume. So, you know, oops. Okay. You've probably, oh gosh, sorry. You probably heard of liver transplants before, heart transplants, lung transplants, but look how low volume that is compared to how many kidney transplants are performed. So while these other organ transplantations are very important, and you know, you might hear it on the news, it's very dramatic, in terms of volume, the kidney transplant organ is by far the most transplanted organ. of these life-saving organs. So what are some current wait list stats? There's about 103,000 people on the wait list for any organ, and 86,000 are on the kidney list. Again, 2023, we did more than 27,000. 2024, again, 27,000, I think like 500. And our entire SoCal area from Los Angeles, Orange County, Riverside, we're all represented by One Legacy as the main organ procurement organization. And so, meaning like if you're at Cedars-Sinai or at UCI, they're all competing for the same kidneys in this region. So one thing to note, if you're faced with kidney disease and kidney failure, this is a very important slide to know in our area. In the United States, the average wait time for a kidney is 4 to 5 years. In Southern California, it's 8 to 10 years. This is the worst place to be waiting for an organ transplant when it comes to kidney. And sometimes on the news they say, oh, like yesterday, Nate Robinson found a match, and they make it dramatic. There's only 4 blood types, and for most part, you're gonna match your blood type or blood type compatible. So an O, if anyone here is blood type O, you guys are amazing like blood donors. You can donate a blood and anyone can receive it. You could donate a kidney and anyone can receive it. But if you're a O patient, you can only get from a O. And so their wait time is 10 years. If you're an AB patient, you're a taker. You can take from anybody. And so my transplant list has 800 people. There's 3 that are AB because we've transplanted them all. So an AB blood type can get a kidney from an AB person, a O, a B, or an A. An A blood type can get it from an O or an A. A B blood type can just get it from an O or a B. And so that's why their wait times are structured the way they are. And that wait time is either from when you start, the day you start dialysis, or if you're referred for transplant before you start dialysis, the day that transplant center puts you on the list. And you can only be referred or get on the list if your percentage of kidney function is less than 20%. So you can't say, oh, I have lupus and my kidney's perfect, let me go put myself on the list if it's this long. You're not allowed to be on the list until your kidney function is at less than 20%. So when we evaluate patients who have kidney disease or end-stage kidney disease, again, their kidney function has to be under 20%. And then if you qualify your position on the list, it's not about how sick you are, it's not about how much money you have, it's not about anything other than what is your blood type and when did you start dialysis? Or get listed. What was the day you got listed? Whichever one's first. So I evaluated a patient yesterday who started dialysis in 2017. If we put him on the list, he doesn't just go to the bottom of the list. All his dialysis time will take him towards the top. And so that's something to know. And then when we do evaluation, we really have to make sure the person's healthy enough to get the surgery, to get the immunosuppression, to go through all of this. And sometimes patients are sometimes too ill to qualify for a kidney transplant. We do cardiac and abdominal imaging, blood tests, and then we look at how functional the patient is as we decide their candidacy. Because you guys are from the SoCal area, I'm just giving you some data about all the transplant programs. Here at UCI, we do about 200, 222 transplants a year. St. Joseph's across the street does about 100, 115. UCLA is the fifth biggest transplant program in the country. They do 350, 375. Cedars is now catching up. They're doing about 300, 325 transplant. USC does about 170, 200 about, and then Loma Linda is about 250, and then Harbor UCLA in Torrance does about 30. And then all of our centers, we're all represented by One Legacy. So if I have a patient at UCI and there's a patient at Cedars, they'll get the same organ offer. And it's up to each program whether they're gonna take that kidney or not. One thing that's shifting in transplant is before, let's say I wanted to donate to my brother, but we were different blood types. It would just end. They would just be like, sorry, you can't donate to your brother, you have a different blood type. But now we started getting, smart about it. We're like, well, if I can't donate to my brother with a different blood type, but in that room, they had different blood types and they couldn't donate, can I donate to her and then he donate to my brother? And we started doing swaps. And then that created the National Kidney Registry. So now UCI is part of this pool of like 80 hospitals where we put in all our uncompatible pairs, and we're able to create chains. And so now the most, like the related number transplants from, hello? Yeah, transplants from people that are related is going down, and unrelated is going up as we're shifting and we're making use of more of these organs. So this is like the scenario I described. You know, this pair wants to donate, but they're blood type incompatible. This wanted to donate, they're blood type incompatible. Instead, this person donates here, and that person donates there. And we bring them in the same day. It feels like your wife, you know, donated a kidney, but her kidney went into that operating room, and then the other person's cousin's kidney came to you, and everyone recovers, and it works out well. That's within us. We get more complicated when we use the National Kidney Registry and we use other hospitals, donors. There are some amazing people that just donate and they don't have anyone to donate to. They just want to donate a kidney, and they know there's kidney disease in America. They don't have a particular patient that they want to give it to. We call those altruistic donors or non-directed. And if we get one of those, then that can unlock sometimes all these uncompatible pairs, and you get these chains of like 7, 8 people that get a kidney transplant, and then you close the chain with someone on the waiting list, the deceased donor waiting list. So we can try to be creative about living donation with this. So contraindications to transplant, you know, something that is hard to talk about to patients if they feel like they want a kidney transplant and they're not healthy enough. Things that we look at, infection. If you have an active bad infection and where you're suppressing your whole immune system, you know, that's going to make that infection more severe, and we wouldn't make you a candidate. If you had a recent cancer and we suppress your immune system, that has to be, you know, weighed. If someone's smoking cigarettes, we won't do an organ transplant. And if you have really bad like heart or liver disease, sometimes you need a dual organ. So some patients need a heart and a kidney, or a liver and a kidney. And then age is kind of controversial. Some programs don't evaluate patients over 70. At UCI, we evaluate anybody, and then we make a case-by-case determination on patient's candidacy. The oldest transplant we did was a 79-year-old who's now 85 and doing great. But certainly that doesn't apply to every single patient, and the functional status becomes important. Kidney transplant, just for you guys to know, like, there's a lot of cost that goes into dialysis care for America. And the most expensive dialysis is hemodialysis, followed by peritoneal dialysis, and transplant is much more cost effective. And so there's a big push, not only just because it extends your life and improves your life, but it also saves the healthcare to spend less money on by transplanting. So some key statistics to just kind of be aware of. Again, Southern California has the longest average wait time in the country, 8 to 10 years. That's too long. And so that's why we have to try to get aggressive about not discarding organs and using kidneys for patients. When you get a kidney transplant, it doesn't last forever. So I sometimes tell patients that are like 35 that, you know, if you get a kidney transplant today, it's, you know, you're most likely going to outlive that. And so, you know, you have to prepare for potentially another transplant in the future. So, you know, make sure you have all blood type O friends that know about your situation so they can help you out in the future. I sometimes explain it like having a car. You know, if your car lasts about 10, 12 years, and then you kind of need a new one. And sometimes that's the average that we see with these kidney transplants. A living donor kidney transplant tends to last a little bit longer. On average, about 15 years. Deceased donors, about 10 to 12 years. We're seeing an older population that's getting kidney failure, so the average age of a waitlist patient is 62 to 64 years old. And the surgery is very, very successful. Like our success rates are expected to be like over 90% at UCI. We're 96, 97% 1 year patient and graft survival. So yesterday I took a kidney and the guy was like, "Is it gonna work?" And I was like, "I mean, I can't guarantee it, but the odds are high." And he's like, I was like, what are we acceptable odds for you to like be excited? And he was like, maybe over 90%. And I was like, yes. But it's either 100% or 0%, you know, but majority of patients do very well. So the other thing that we didn't talk about is the quality of life, because dialysis is very hard. It's hard to travel, it's hard to have children, it's hard to work. And so what has been an extra joy in this field of transplant is to see people working again, traveling again, and having families. You know, I've been part of probably 30 young girls that couldn't have kids when they were on dialysis that are now moms, and walking them through that process is absolutely amazing. And so there's a lot of quality of life that you get back with the organ transplant, besides just staying alive longer. And physical activity, we have 2 patients that ran the marathon last year, and I still don't know how they did it. I try to run 3 miles and I'm done. So compared to dialysis, patients live longer, better quality of life, and so save on overall medical costs, and it is the optimal therapy if you have kidney failures to get a kidney transplant. So that's just the background. Now it's just a little shameless plug or shameful plug for UCI. We just want to introduce our transplant program to you guys. UCI has been in the transplant game for over 50 years. We're the fastest growing transplant program. I think I meant state, so that country sounds dramatic. I should say state. We're the fastest growing kidney transplant in California. If you're online, don't accuse me of lying there. We have excellent outcome scores for the last 10 years. We're now a top 40 transplant program in the United States as far as volume with our 220 transplants. We didn't talk about kidney pancreas because this is not the audience, but for some diabetic patients, we do offer kidney and pancreas transplant. That's an amazing thing that patients can get off insulin and off dialysis in one surgery. In the US, we increased transplantation by 427 transplants from 2024 to 2023. It's not a huge number. At UCI, we increased transplantation by 87 transplants from 2024 to 2023. So just UCI alone has accounted for 20% of the growth for the entire country by being more aggressive is how we did it. This is a chart of like UCI through time. We used to be a program that we're doing 35 to 50 transplants. We got into 100 a few years ago, and now we skyrocket that into over 200. One thing that I think is important is that in this area, the average wait time is 8 to 10 years. And if we just waited for patients to get to the top, a lot of them are going to die. And so what we did a couple years ago is we started realizing that programs are very conservative with organs that are out there. And they want the best kidney because they're scared about having bad outcomes, and they also are like, well, this guy waited 8 years, maybe I'll just wait another week and he'll get a better one. But in that process, a lot of kidneys were being discarded. And so centers like UCI decided to start taking them, but not for the people at the top of the list, finding people in the middle at the bottom. So this weekend we did 4 of these where we talked to the patient and said, we have this kidney, we think it's working well, but in the process of dying, the patient had some kidney issues, but it's not long-term, it's just acute. And we think that this kidney will work. And so we have these conversations and say, you can try to take this kidney now and get off dialysis, or you can wait 6 more years until your name gets to the top. And so we were able to shave in the last year our wait time, instead of 8 to 10 in the community, down to on average of like 4 to 5, which is by being aggressive and using kidneys. Now I have 7 states that call us when they have a hard to place organ because they know that UCI will give it a chance to personalize it to maybe someone at the bottom who doesn't need to wait 9 more years for the perfect kidney, and that there's a decent way to get off dialysis. And we've done it, and we've had amazing outcomes, and so we're going to continue to try to fight and give these people a chance. So last part of this slide is lupus and kidney transplantation, just to kind of tie it in with the theme. So, kidney failure, I think, is one of the most severe manifestations of this disease. Up to 40% of lupus patients will have some degree of CKD, which means chronic kidney disease. And about 10% of those will eventually progress to end-stage kidney disease where they're on dialysis. Some studies estimate that it's 10 to 30% of patients with lupus nephritis who end up needing dialysis. And hopefully with the treatments that you learned about today and the way rheumatology is advancing lupus, we can make a dent into some of these numbers. But if it does happen, this is the world that we're going to enter. We think it's safest to transplant lupus patients when their disease is in remission for 6 months. Usually that's not an issue for us because by the time patients get to the point of dialysis, their lupus tends to be quiescent, and so we can safely transplant. And then if patients do have active lupus symptoms, which they sometimes can, like a rash, arthritis, or flares, those patients do have a higher risk of rejection and complications. But when you compare lupus to non-lupus patients in organ transplantation, they do just the same, so it's not worse. One of the hard parts of my job in organ transplantation is when the original disease that affected the kidney comes back after you transplant. Like you do all of this work and you get them a kidney and that damn disease came back. There are some diseases that do that and it's tough, you have to treat them. Lupus is one of those diseases that has that very low. Like that's not the issue with lupus for most of the cases. And so some diseases can recur at a rate of like 30 to 40%, but lupus nephritis is not one of those. It has a very low recurrence rate, so that's good. If lupus does recur, some of the risk factors for that is young age, female, non-Hispanic ancestry, and then some patients will remain on Plaquenil due to observational studies of improved outcomes when patients take Plaquenil. And so I think this is rounding out the last couple slides. The survival rate for lupus is about the same. Adherence is always going to be important. And then regular lupus monitoring by the rheumatologist is encouraged to watch for new flares or new autoimmune symptoms. Last slide. So CKD and ESRD, definitely a possible complication of lupus if the disease affects the kidney. And transplant is a way to offer, quality of life, life expectancy, and finding a living donor is the way to decrease the wait time for a kidney transplant, and our program is here to serve you in any way. So,
thank you so much, Dr.
Thank you for
Reddy.
your time.
We're gonna take a couple questions in the room in one moment. I'm just gonna ask one question from our streaming audience. How long does it take to get a family member assessed for validity on the kidney swap program if they aren't a match for you but could give it to someone else? Is it just a blood test or are there more tests that they have to do?
So I think the question is about how long does it take to evaluate a living donor? Yeah, so living donor evaluations don't take too long, but we do so many tests that it feels like we don't want your kidney. It's just how it is. Like, it's just how it is. You have to protect the living donor. Like, that is not a patient. We don't want to create two patients out of one. So a living donor assessment is usually done in a day. As part of any living donor assessment, there's a psych consult just to make sure, social work, and physician, surgeon, and nephrologist. And then there's just blood tests to make sure your kidney's okay, imaging tests to make sure your kidney anatomy is okay and the surgery is not too risky. And then after that, we present the patient in a selection committee where we approve a living donor. So all of that usually is under 3 months. Sometimes a living donor, we find this, and then that turns to, oh, you need a colonoscopy. And then that turns to, we gotta clear you from GI. And so sometimes it could be longer. But the more important is that what I tell the recipients, because no recipient's like, yeah, take my son's kidney and give it to me, right? They're like, I don't want you to take my son's kidney. But we have to change that conversation, and I say, I understand why you say that, but understand that the program feels that too. And if we clear this son, that he's actually gonna be okay. And that we are not gonna take the son that is not okay. And then that helps them kind of get to that point of accepting their own child's kidney, which is very hard navigation to do. So we're very thorough in in that living donor assessment, but it doesn't take too much time, because usually the way I look at living donor is like, this is a healthy person, right? And so if they have, diabetes, they're already out. If they're on like 3 blood pressure meds, they're out. And so when we sift through that, the ones that we get, the workup usually is not that long.
Thank you. Questions in the room?
Yes, one of the questions that I had is, my fiance is an end-stage kidney failure patient, and we are on the transplant list. However, I don't really hear a lot of information about the living donor program. I don't really see campaigns about it. I don't see information readily available for people like me and him who advocate for kidney transplants. We work with the American Kidney Fund. So we haven't really seen, and that's something I've brought up with the American Kidney Fund, that we don't really see much literature or information to properly explain to people so that they might be interested in becoming a living donor. What is being done to rectify that? Is there something that your clinic is maybe studying or, has found that this is a way to approach that subject or to properly communicate that with a living donor?
Right. That's an amazing point, and it's a very valid situation. There's not enough information about living donation. Like when I said there's 6,000 living donors, like even that part of the story is just kind of glossed over. At UCI, we have two challenges. One is exactly what you described, there's no information. And two, we represent a heavily Hispanic community, where 67% of the patients we transplant are Hispanic. And finding a living donor sometimes in that community because of genetic risk factors, we're not as successful as other areas where there's much more living donation percentage. So at UCI, we have something called a microsite. It's an individualized website that helps patients get their information out. What I've seen successful, when I ask patients like, how'd you, in next month we have these high school friends that are donating to each other, and sometimes it's just like a Facebook post, and then someone will feel something, and then it moves. And it's amazing the world we're in, because there are donors out there, but it's hard to pluck them. So the microsite is one thing that we are trying to use to give a patient an individualized website that they can see, that can send to people, and it helps them find a living donor. The other thing is education. So we work with the National Kidney Registry. They have a campaign called like Big Ask, Big Give. And it teaches patients how to approach family members. And we have a campaign with them all in Spanish, because one challenge is how to increase living donation rate amongst Hispanic patients. And that has helped, and it's on our website at UCI. But I agree with you. I mean, I think your question is more societal, that there's not that much information about living donation. And I think there's a lot of people out there that can make a dent in it. And so when I see the pig transplants, I'm like, that's cool, but I honestly don't believe that organ will last 20 years right now. It'll get you out of, you'll make the news and go out, New York Times will publish it, but like 2 months down the road, there's gonna be rejection, the organ's not gonna last. Yeah, of course, everyone is. And I'm not discounting it, but I think in 2024, we're not there yet. And there are a lot of people in this country that can possibly donate a kidney and change this whole paradigm. And they're willing to, yeah. Yep. Right. I agree. Oh, hi.
Hi, good afternoon. Great presentation. What if your data or statistics for those individuals when kidney rejects? I had 2 kidney transplants.
Okay.
I had one in 2002, and then it rejected a year later. And then I got another kidney transplant in 2005. So right now, the kidney that I have now is from 2005. I am one of those O blood types. I'm O negative. Though no one in my family had matched, because I'm the only person in my family who's an O. So, I have gotten, my first transplant was a living donor, and then my second transplant was a deceased donor. So what is your statistics about kidney rejection? And if the kidney rejects, how often does that recipient can be back on the transplant list? Because sometimes you may not get back on the transplant list, and you won't qualify to be back on the transplant list?
Yeah, I mean, I don't think there's a simple answer to your question. I don't have stats about our percent of rejection, but it's less than 10%, which is a lot lower than what's published out there. At UCI, for our induction of transplant, we use something called thymoglobulin, which is the strongest agent that we have, and we use that over 95% of the times. So our rejection rates tend to be a little bit lower, but there's sometimes a price you pay for that, because then you have a little bit higher infection rates because you're using more immunosuppression. So rejection is a terrible word, right? The word rejection, no one wants to hear that. But sometimes to a kidney, there's degrees of rejection. What rejection is, to me, what I tell patients is it's a lot of inflammation. And so sometimes when we biopsy it, it's mild rejection. Sometimes it's moderate, sometimes it's severe. Now, to your question of well, then what happens to the organ after that? It totally depends on the type of rejection and how long that rejection is going on. So one thing we realized here is to have really good outcomes, you have to see patients way more than anyone else. So when I was at UCLA, after 3 months, we would never see the patient. The community providers would take care of the patients, and we assumed everything was good. Here, it's a different game, and so we see patients very closely for a year. So we can catch rejection fast because we're watching, and so I think that's important, how long the rejection is going on. And then if your kidney did fail and you were back on dialysis, whether it was from rejection or it was 10 years, 15 years organ and it failed, it doesn't matter. You would be a candidate again for transplant. The one time it matters is if we get word or the reason your kidney failed is you didn't take your meds for a month and you lost your kidney, right? So now we have to make sure that person understands that what's needed on the second time. And sometimes that happens with kids. They sometimes get an organ and then they don't take their meds for 2 months and the organ rejects, and then we educate them and relist them. So having rejection shouldn't usually cause you not to be back on the list again. It would be overall health, and a reevaluation of the patient as a whole. And the main thing I wanted to tell you is 20 years with your transplant, that's amazing. That deserves its own applause. When I go talk to the patient today and we're about to transplant him, I could say, oh yeah, I just met a patient who's had their transplant for 20 years, and that gives them hope. So congratulations to you, that's amazing.
We have one more question here, Dr.
Hey, doctor, thank you again for all of this. I know you mentioned that 8 to 10 years is an average here, and that's pretty bad here for Southern California. But if you're out of the area and you're trying to be proactive, are we allowed to say join these other transplant programs in other cities? I'm from San Diego, and if to me, being proactive and expanding my search for a kidney donor is to say get involved with UCI, and I'd like to, but is that allowed, or what are the restrictions?
Yeah, definitely come to UCI. That's one. We're not too far from you, and you have a high chance of getting off the list. You bring up a really, really important question that I freely tell all my patients. This area sucks. San Diego too. For waiting for a kidney transplant, this ain't the place. If you don't have a living donor, we have to think outside of SoCal. The places that come to mind is Mayo, Arizona has a 4 to 5 year wait time. It depends on your insurance whether they're gonna cover that. So sometimes those are rate limiting steps. But Mayo, Arizona 4 to 5 year wait, and Utah, Intermountain. So I even have the link and I give the patient, and I know the Utah guys, I'm like, this person's coming. Utah Intermountain has a 3 to 5 year wait. And then I've had patients that live in our area. I learn from the patients because they go do the hustling and then they come back to me to take care of their organ. And I'm like, what'd you do? And he's like, I went to Oklahoma. And I'm like, damn. And then I start learning about it and I can tell other patients. So the places I've seen it happen is Mayo, Arizona, Utah Intermountain, Nebraska, not Oklahoma, Nebraska. And then I have patients that have gone to Iowa where there's less than a 1 to 2 year wait. But some of those programs will require you to prove that you can fly there on a moment's notice, right? Because we have to use those organs. Today I got a kidney at 9 a.m. from the Bay and it's coming here at 3, right? It moves that fast. And if you're in Iowa, you're not gonna be able to use that kidney.
You gotta get going.
Huh?
Don't you have to get going?
Yes, I mean, But that's how quickly it moves. You have to use that organ within a day. So those are what I would tell you. I would tell you definitely. I mean, just like you're not too far. You can come to UCI. You can be listed at multiple places, but you have to have one as your primary. And if you live in San Diego, that's fine to have that. Yeah.
Thank you so much, Dr. Reddy. Thank you.
Thank you.
Thank you so much. Okay, thanks. All right, we're going to take a moment for everybody in the room. We're going to draw a raffle right now. Please meet a member of our Lupus LA team, Mia Gunzenhauser, who will do the honors. Oh, yeah, this works.
Hi, everyone.
Tickets.
Hi, everyone. Yeah, grab your tickets. We're going to be doing a random drawing of 3 winners today. We'll be doing by the last 3, correct? Okay, our first number is 996. Our next winner is 993. 993? Okay.
Going once, going twice.
All right, we're going to move on to 927. 927. Yay. And last but not least, we have 990. All right.
Woo-hoo.
Thank you, everyone.
Thank you, everyone, so much for joining us in the room and online today. On behalf of everyone at Lupus LA, I want to thank you all for coming. If you're looking to get more involved with us or share your story, no matter where you are, we encourage you to reach out to us on social media, send us a direct message, or email us at info@lupusla.org so we can get to know you. Thank you all for coming.